Okay, students, here we go. Gonna knock this out. So chapter 11, caring for the woman experiencing complications during pregnancy. So I'm going to cover most of these slides, but not, I don't think, all of them. But we'll see how it goes. Okay, so just definition-wise, perinatal loss is any death of the fetus or newborn, or birth of a less than perfect child. Okay, so the baby didn't actually die, but not a perfect child. Baby has some problems. And then the perinatal period is any time from conception through the neonatal period, which is 1 month after birth. All right. Okay. Ectopic pregnancy. So one of the complications that they may have is called an ectopic pregnancy. So that is when the egg is fertilized, and fertilization always happens in the fallopian tubes, but implantation happens in the uterus. So a fertilized egg implants outside of the uterine cavity. So basically it could be anywhere, but it's not in the uterus. All right. They most often happen in the fallopian tube, but they can be on the ovary, on the cervix, on the abdominal wall, on the bowel. Okay, that's crazy, right? So yeah, it could be one of those places. So what we would see is we might see some vaginal bleeding. She might miss her period. She'll have abdominal tenderness and pain. So when she starts having more than tenderness, when it starts being like painful, like a bad painful, that you probably usually means that she has ruptured the pregnancy, or the contents of the pregnancy, or the fallopian tubes have ruptured or damaged. She could have some referred shoulder pain. But anyways, the other things is she could have hypotension, tachycardia, or vertigo. Okay, so risk factors associated with that is you can read here, current or past medical complications, prior ectopic pregnancies, history of sexually transmitted diseases, pelvic inflammatory disease. You can see these risk factors. Now, with that being said, it's not like I don't want you to know these risk factors. I don't want you to memorize them, but just kind of be aware of them, but they are not on your exam. So here's just a picture of possible places for an ectopic pregnancy. But you can, oh, why am I not making this big? Sorry. You can see here that this is in the fallopian tube. So this pregnancy grows, all right? And that fallopian tube is only so big. So hopefully we can get that before it ruptures her fallopian tube. Anyways, we diagnose based on signs and symptoms. We may feel a palpable mass on bimanual exam. So bimanual means through the vagina and then over the abdomen, okay? So her HCG, or human chorionic gonadotropin, will be, she'll have that blood draw, but it'll be lower than what we would expect for how many weeks she is. She would have an elevated blood pressure, and then we could also see this on transvaginal ultrasound. So, how do we manage these? So there's a couple of different things. So let's drop down to the bottom. So hopefully we catch this before that pregnancy gets bigger than that is larger than a 1.6 inch diameter, basically. Any bigger than that, that is too far along for us to give this medication, methotrexate. Okay, it's a chemotherapeutic drug. It stops the production of the trophoblastic tissue, or destroys what's there of trophoblastic tissue. The trophoblastic tissue, we haven't learned this yet. We will learn this in the future, but that is basically the cells or the tissue that develops into the placenta. Okay, so it stops that from happening, and then she can pass that pregnancy. Otherwise, we're going to be doing a laparotomy or a laparoscopic, a laparotomy assisted salpingectomy or a laparoscopic assisted salpingostomy. Okay, so with the first one, we actually remove the ruptured tube. Okay, we make an incision in the abdomen and remove. So the ectopic pregnancy grew, ruptured the fallopian tube, and we remove that. So the second one is we go in with laparoscope, a small little puncture or incision, a tiny little incision, and we stick this laparoscopic thing so it has like a little camera on it, and we remove that part of, we cut open into the tube and remove that part of the pregnancy. All right. So another complication is gestational trophoblastic disease, and there's several different kinds. Okay, so basically this is a abnormal placental development, and what it looks like is fluid-like. So it just looks like a cluster of grapes, is what this looks like, and it these clusters of grapes are full of blood. Okay, so there's several different kinds. So there's the hadadidiform mole, and there's two different kinds of those. So that's the one we call the molar pregnancy. So there's either the complete molar pregnancy or the incomplete molar pregnancy. The complete molar pregnancy is that an egg was fertilized. Okay, so there was an egg and sperm, and they fertilized, but the egg contained absolutely no chromosomes from the mother. It was basically an empty egg. Okay, and a complete molar pregnancy is related to increased risk of malignancy. Now the incomplete mole, so this happens when the egg is fertilized, so we have the egg and the sperm, but there's a couple of different ways. So we have a normal egg with a normal amount of chromosomes, which is 23. But for some reason, that egg got fertilized by two sperm, and those two sperm each have 23 chromosomes. So it's 23 plus 23 plus 23 chromosomes, which is not okay. All right? Or it's fertilized by a sperm that has failed to undergo the first meiotic division. Now, we haven't learned that yet, but just know that when we start the meiotic process, we start with a cell that has 46 chromosomes. Okay? So before the first meiotic division, or meiotic, I'm sorry, no, I was right, meiotic division, that's how you pronounce it. We have 46 chromosomes, then it divides, and then there's 23 chromosomes in each one of those divisions. But we'll go through that at some other time. So that's what happens. So we have a normal egg with 23 chromosomes that's fertilized by either two sperm, each with 23 chromosomes, or we have a normal egg, 23 chromosomes, that's fertilized by a sperm who has 46 chromosomes because it did not undergo the first meiotic division. Okay, so what ends up happening is we have a fertilized egg that has 69 chromosomes. Okay, that's not compatible with life. All right, but there's a very low risk of malignancy with this one for some reason. Okay, so trophoblastic disease, we have the hadadidiform mole, which is the molar pregnancy. We have the two different kinds. And then we have the invasive mole and the choriocarcinoma. Okay, so the invasive mole is really similar to a complete mole, but it doesn't invade the myometrium. So the difference is, the invasive mole has invaded the myometrium. So it's basically implanted. But for some reason, this one does not metastasize. So who knows? Anyways, the choriocarcinoma is invasive malignant disease, or gestational trophoblastic disease, and it usually metastasizes to the lungs, the liver, the brain, the intestines. This is really bad and it's fatal. Okay, so the risk factors for this, you can read the risk factors for this. Again, I'm not testing you on risk factors. These are your symptoms. So we have vaginal bleeding that can be just a little bit, or it can be profuse. The woman will have abnormal, excessive nausea and vomiting. She will have abdominal pain. The size of her pregnancy does not agree with her dates. So anyways, those are the signs and symptoms, which just be aware. So this is a bleeding disorder, basically, a gestational trophoblastic disease. There's a couple of different kinds, and this, shoot, I hate to say this, this is not on your test, but know about gestational trophoblastic disease or molar pregnancies. Okay, they're not. They were from a fertilized egg, but there's funky things going on with the chromosomes, so these are not compatible with life pregnancies. Okay. So the management is we remove the contents, and then we'll run serial HCG levels until none is detected. Okay, so that we make sure everything is gone, and then we do them every couple of months for a year. Okay, and we don't want the woman to get pregnant during that year. The invasive moles we just need to give chemotherapy for, and then the choriocarcinomas, of course, she's going to have chemotherapy. She may have a hysterectomy, may need radiation. This woman's, it has metastasized, so this is a terminal diagnosis. And that's why we, under the management section, that's why we check these women every 1 to 2 months for a year. We want to make sure that the contents of that pregnancy are gone, and then I think these women also get tested every 3 years if they're not pregnant. Okay, moving on. Spontaneous abortion. So pay attention here. So first of all, spontaneous abortion, that's what we call a miscarriage. The medical term for a miscarriage is a spontaneous abortion. Okay, but don't use, oh, I see you've had 2 spontaneous abortions. The woman will come out of the bed. Okay, because we, the general public, when they hear the word abortion, they think that this is something that the woman went to a clinic and got an abortion, a removal of the pregnancy. But that's not, and medically, that's, we use the word abortion for a lost pregnancy less than 20 weeks. Okay, so an abortion, whether it's elective or spontaneous, is a loss of pregnancy before 20 weeks. Now, there's the early loss, there's the late loss. Okay, and the reason why that people have spontaneous abortions is probably has a lot to do with chromosome abnormalities, like incompatible with life type chromosome abnormalities, where they can't even maintain gestation. All right, infections, problems, maternal problems. Okay, that she cannot support the pregnancy. And then sometimes we can't identify a reason. All right, late losses, so past 12 weeks to 20 weeks, like maybe there's an infection that mom has, or maybe she's using recreational drugs, or maybe she has some sort of uterine or cervical defect that doesn't support the pregnancy. So there's a lot of reasons why these can happen. Signs and symptoms: bleeding, cramping, abdominal pain. Because when they're losing this pregnancy, of course, they're going to be bleeding just like as if they gave birth to a term baby. They're going to have cramping and or abdominal pain. So diagnosis-wise, we base it on signs and symptoms. We can do an ultrasound. Her HCG levels are going to be lower than what we would anticipate for pregnancy at that gestational age. We can do an H&H on mom. We'll need to do ABO and RH and an indirect Coombs, and this is because of RH negative mothers. So we'll talk more about that now, but just know that RH negative mothers, we can't test this spontaneous abortion to see what the baby was, so we just assume that the baby was RH positive, so we treat mom as long as she was not sensitized. Okay, and we know if she's sensitized by the indirect Coombs. Okay, but basically we just give support to this woman. She passes her the products of her pregnancy, and we intervene only if we need to. Okay. Now, there's several different kinds of spontaneous abortions, and these are only important. These are important, okay? But some of them may be a little more problematic than the others. So a complete abortion is just the way it sounds. All the products of the pregnancy have been passed, okay? It's completely gone, okay? An incomplete abortion is only part of the pregnancy has been passed, okay? Now, if this occurs, this woman is at more a risk of more bleeding, all right? Or infection. An inevitable abortion is like she has not expelled the products of the pregnancy, but she's bleeding and dilating, so it will happen. So that's why it's inevitable, okay? A threatened abortion is she's bleeding, but she's not dilating, okay? And she hasn't expelled the products of pregnancy. So a threatened abortion is it seems like she's going to abort, and she may indeed abort. However, this may be okay. If we put this woman on bed rest, maybe it'll be okay. Who knows? But the reason why it's threatening to abort is maybe there is a problem with the baby, okay, or the mother or something. But a threatened abortion is she's bleeding but she's not dilating. An inevitable abortion is she is bleeding and dilating. So those are the difference between those two. Okay, a missed abortion is so she's bleeding, she's dilated, but she hasn't passed any of the products of conception. The baby has died, and she has not passed. Okay, a septic abortion is because she has not passed the products of the pregnancy, then she becomes infected. And then a recurrent abortion is a woman who has 2 or more successive pregnancies that abort, okay? And some women do. All right, enough of that. So cervical insufficiency or cervical incompetence. So that is when the cervix cannot retain the placenta. So what happens is the cervix dilates. It effaces and it dilates, and the pregnancy is lost because it passes, all right? It's painless, though. Like, she's not having contractions. She's not feeling contractions. She may have no bleeding at all. And all of a sudden, she's completely dilated and the baby passes. So this is called cervical insufficiency or cervical incompetence, okay? So we diagnose this with a woman who has a history of loss in the 2nd trimester. So after, well, not necessarily after 20 weeks, but somewhere in the 2nd trimester, we do transvaginal ultrasound, and we look at her cervical length. So if she has a transvaginal ultrasound cervical length that's less than 2.5 centimeters, she's at risk for cervical insufficiency. And if she's dilated more than a centimeter with shortening or effacement and funneling. So what funneling is well, I'd have to show you. I don't know if I can explain it, but their cervix starts to funnel, okay? So it starts to open at the top and look like a funnel, okay? But anyways, management is we do a cerclage. Cerclage is a surgical procedure where we stitch that cervix closed and don't let it open. And the pregnancy can be maintained, and a very healthy pregnancy. And at 37 weeks, we cut those stitches, so when the woman dilates and goes into labor, then great. But at 30 weeks, that's fine, okay? Once we do the cerclage, so we bring them in the hospital, it's a surgical procedure. We give them tocolytics, so these are the things that, these are medications that keep her from contracting, because we just mess with the cervix and the uterus and vaginally, and it may have irritated and inflamed the uterus where it starts maybe contracting. So we give her some tocolytics, we give her pain medicine, we keep her in the hospital for 24 hours and make sure everything settles down. She's on bed rest, and then if everything is fine, then we let her go home and live her life, and hopefully she comes back 37 weeks and get that cerclage cut, and then hopefully she stays pregnant for even another week or two. Anyways, okay. Hyperemesis gravidarum. I'm trying to. I don't think I have anything on this on the exam. But you need to know about hyperemesis gravidarum. So we all know that pregnant women can have morning sickness. Well, this is a morning sickness on steroids because it doesn't stop. This is dangerous for both mother and baby, okay? So this is a persistent vomiting. Women can actually suffer starvation and severe weight loss and lose their pregnancy because they're just not able to take any food in, like they're not. Okay, so what we do to try to manage this is rest. We try frequent small meals, but that sometimes doesn't work. High protein snacks, but hyperemesis gravidarum, these people can't even sniff water and it makes them vomit, like whatever is causing it. Okay, so you see what it's related to up there. So a lot of times these women are hospitalized. We start an IV, give them IV fluids. We make them NPO or nothing by mouth because they can't keep anything down. So we're just trying to settle down their gut in hopes that they can get past it. But typically if they can't, I've taken care of a lot of women who have to actually be on total parenteral nutrition. Okay, they get PICC lines and everything. So we can feed them as much antiemetics as possible, but as soon as you put food to their face, they start to vomit. Oh gosh, this is starting again. Hemorrhage disorders. Oh my gosh, I don't know. Oh my gosh, this is going to be bad. Okay, so this is, I want you to pay attention to this. Oh my gosh, let me pause and see if I can stop this craziness. Alright, so this is going to take forever because I couldn't figure out how to do it. I went to transitions and did all that stuff. So sorry guys, like I hate that. Oh god, this is going to take forever. Hemorrhagic disorders. So pay attention. Placenta previa, very common. Well, not very common, but this is pretty common. You'll probably inevitably have a patient or hear of a patient with placenta previa. So this is an abnormal, not abnormal, well, sort of. A placental implantation in the lower uterine segment, okay, near the cervix, okay. So usually the placenta's implant at the top and posterior part of the uterus, but this one for some reason went in the low uterine segment. So there's a couple of different types. Complete, partial, marginal, and low-lying. Okay, they're diagnosed in the second trimester. Signs and symptoms are painless vaginal bleeding. So what happens with a placenta previa? So the placenta is down there by the cervix, and depending on how close it is to the cervix, so if you've got that fresh placenta over the cervix, then the bleeding that's supposed to be exchanged between the placenta and the uterus is actually bleeding out the cervix. Okay, so if it's a hold on. All right, if it's a complete previa, that means it's completely covering the cervix. Okay, so it can be bleeding right out the cervix instead of exchanging blood from the placenta to the uterus. So if it's completely covering the cervix, guess what? Like, she can't have a vaginal delivery. Okay, if it's a partial, then only a part of the placenta is covering the cervix, and that part is bleeding right through the cervix, and this one cannot have a vaginal delivery. If it's a marginal, now depending on how marginal it is, so marginal means like the edge of the placenta is close to the edge of the cervix. Now the problem here is as that woman dilates and that cervix opens, then that cervix starts exposing placenta. So this one may not be able to be delivered vaginally. The low-lying placenta, we do a lot of low-lying placenta deliveries, okay? So it's just low in the uterus. It's not next to the cervix. It's not over the cervix. It's not bleeding out the cervix, okay? But anyways, signs and symptoms with these are vaginal bleeding. Now, when we do a Leopold's maneuver, we might find baby in a breech or an oblique lie. So the babies are laying sideways, and so the reason why this is because that big old placenta is down there and it doesn't allow baby to get in the right position. Okay, so we do not do vag exams on these previas because we don't want to be poking that placenta. All right, we may see late fetal heart rate decelerations. We may see a bradycardia, absent variability, and we may even see a fetal demise because depending on how much bleeding mom has had. Okay, so what we do for management is they're on bed rest. We stabilize them or stabilize their bleeding or stabilize them while they're bleeding. We monitor the baby and we give IV fluids. Now, we want to draw these labs. Of course, a CBC, a PT. We want to do these clotting studies, PT, PTT, fibrin, split products, fibrinogen. These are all blood clotting lab tests because the more our moms bleed, the more they use up their clotting factors, okay? So anyways, and then we do a Kleihara-Becky test that detects fetal cells in maternal blood, okay? For Rh negative moms that are unsensitized, we give them RhoGAM, betamethasone, because if we can keep this woman pregnant even for 24 hours to 36 hours, then depending on when we have to have this woman delivered, betamethasone is what we give to help baby boost their production of surfactant, which is what they need in their lungs so that they can breathe without their lungs collapsing. Okay, we'll talk more about betamethasone. So then we need to decide, do we need to deliver right now? Is this mom starting to get so unstable, and or is the baby getting so unstable that the safest thing for both is to deliver this baby, even if she's only 34 weeks or younger? Okay, so we just need to weigh the pros and cons of keeping baby in utero or getting baby out. And can she do a vaginal delivery, or does she need to be delivered by C-section? So it really just depends on where, one, that placenta is, and two, the stability of both mom and babe. Because even if we have placenta where we can do a vaginal delivery, if she's lost enough blood and baby is not doing well, like they cannot tolerate a labor. So there she would get a C-section. And here's just some pictures. So this is a picture of the placenta. So this is the placenta. Okay, this is the cervix right here. Okay, so you can see that placenta is just bleeding out the cervix. Instead of this placenta being attached completely to the uterine wall and exchanging blood from the uterus to the placenta, then it's just going right out. Okay. This is a partial, so only part of the cervix is covering, only part of the placenta is covering the cervix, and again, this one cannot be delivered vaginally. Here's marginal, so where's my cursor? So the very edge of the placenta is at the very edge of the cervix. It does bleed, and then the thing is, as this cervix starts to dilate, you can see how it will expose more of the placenta, possibly. Okay, and then I don't have a picture of the low lying because it's just a placenta in the uterus. It's just low in the uterus. Okay, I tried to fix this, but I couldn't figure it out, so I don't know what to do. I don't even know how this started. Okay, so some more problems is abruptio placenta or placental abruption. Listen to this one as well. So this is a premature separation of the placenta from the uterus. I should have typed that in. Premature separation of the placenta from the uterus. Okay, there's a couple of different types, of course. Gotta make it confusing. There's the central or concealed abruption. There's the partial abruption and the complete abruption. Okay, so signs and symptoms are third trimester bleeding, or whenever this abrupts, but usually it's in the third trimester, and when she's having an abruption, she's having severe abdominal pain, and we can palpate this as a tense uterus, not a resting uterus. Okay, she may have back pain, When we palpate, it's a board-like abdomen. And we may see no bleeding at all, especially if it's a central or concealed, okay, and we'll talk about that. She'll have an abnormal contraction pattern, and sometimes she'll have these little tiny heels just all across the paper that don't look like very strong contractions, but they're happening every 40 to 60 seconds, and so there's an appearance to the way they look that the nurse will be suspicious that this is an abruption, okay? We might have baby saying, my mom is losing blood and I'm not doing well. She'll have late decelerations, bradycardia, absent variability, and may even die, okay? Risk factors: hypertension, smoking, illegal drug use, short umbilical cord. So short umbilical cord, so for whatever reason baby was tugging on the cord because it was so short with baby's movements or whatever, and pulled the placenta away from the uterus, okay? Abdominal trauma, car wreck, she got beat up by her boyfriend, he punched her in the belly. A rupture of membranes can cause this. Lyomas can cause this, all right? Anyways, it's diagnosed by clinical findings and then ultrasound. So sometimes we'll do the ultrasound and we won't see any abruption at all, okay? So they're not always 100% true. But we will go on clinical findings and signs and symptoms. So what do we do? Depends on the bleeding. And did the bleeding stop? Okay, and depends on us monitoring baby. Is baby doing okay? So if this is we'll talk about it in a minute. So depending on what kind of abruption she has, that bleeding may end up stopping, okay, and she may go on about life while she's pregnant until she's term. But sometimes they don't stop bleeding. So the labs that we're going to get is basically the same as the Previa. We want a CBC and we want these clotting studies. And then again, a Kleihauer-Becky to detect fetal cells. We also, if my mom is Rh negative and unsensitized, we're going to give RhoGAM. We're also going to give betamethasone. So if we can keep this patient pregnant for 24 to 36 hours, or we'll give this betamethasone to mom so that baby, so this helps baby, remember, produce the surfactant, okay, for the lungs, all right? And then we need to decide whether we need to deliver, and can we deliver vaginally? I'm sorry, let's back up. Do we need to deliver right now even though she's only 32 weeks? Or is she term or close to term, and can we do a vaginal delivery, or do we need to go straight to C-section? So let's look at these abruptions. Okay, so the first one is a partial abruption. Okay, so just part of, the first one is a concealed abruption, and yes, it is partial because the placenta hasn't completely separated, but this is your concealed abruption. So you can see that all this tissue right here is placenta, okay? And all of this tissue here and here is adhered to the uterine wall. It's the center of this placenta, not the edge. This looks like it's the edge of the placenta, but they're just kind of trying to show you this cross section here. So all edges are adhered to the placenta, and then in the middle she started bleeding. Now the one thing that's bad about this is, one, you don't see any blood, okay, because it's all concealed. And number two, so if this bleeding continues and continues and continues and creates such pressure in there that the bleeding now starts penetrating into the uterine wall, okay, into the uterus, into the uterine muscle, what's going to happen is that blood that has penetrated through is going to tamponade off all those vessels in the uterus right there in that area, and actually cause what you would know as an infarct in the heart. So there's no blood or oxygen getting to those tissues, so those cells die. That tissue dies. This is called Cuvier uterus or something like that. And if you were to look at this uterus, it would have a bluish color because there's no oxygen-rich blood circulating through there. Anyways, so that is your concealed or abruption. Now, the other thing about this concealed abruption is maybe it bleeds, and the pressure of the bleeding actually tamponades the vessels in this uterus, causing them to, basically putting pressure and stopping the bleeding. That would be great. And here's your partial abruption. So this is the partial abruption. So you see all this uterine tissue here is still all this placental tissue here is still adhered to the uterine wall, and this placental tissue has come away from the uterine wall, and all this is bleeding. Okay, so you would see this blood, okay? But depending on the severity of this, it might clot off, it might not. She might continue bleeding. And here is a complete abruption. So what is going on is the entire placenta has broken away from, and this says concealed. So pretend like you don't see concealed, okay? Concealed is concealed is concealed. So if it's a small conceal or a large conceal. But what I want to talk to you about is a complete separation of the placenta. So this bleeding would be coming out. So I'm sorry about this picture. I should have reviewed it a little more. So anyways, those are the two differences. So depending on how much she's bleeding, depending on if the bleeding continues, depending on the baby's reaction to this blood loss, depends on how we need to treat this, if we need to deliver right away, if we can just put her on bed rest and let everything settle down, or what. But this complete separation, there's no going back from that. This partial separation, depending on the degree of separation, there may be no going back from that as well. If it was just a little partial part and it clotted off, we might be okay. But again, we only know what baby tells us, okay? So if baby tells us this isn't good, then it's not good. Baby's the boss. All right. Okay, enough of abruption. Preterm labor is, so I don't know if we talked about, I think we did, true labor versus false labor, but there's cervical change in true labor. So if it happens while she's preterm, so that's before 37 weeks, cervical change and regular contractions before 37 weeks, so 20 to 37 weeks is preterm labor. Now remember, if this is occurring before 20 weeks, what is it? It's an abortion, okay? So a preterm birth between 20 and 36 and 7 weeks, or 37 weeks. This is silly. So preterm birth is a birth between those weeks. See box 11.4 for risk factors. Like, there's too numerous for me to put on these slides. So look at the risk factors. Kind of be aware of them. You don't have to memorize them, but you can look at them and see, oh yeah, I can see why this would cause someone to go into preterm labor, okay? So the signs can be subtle. Like, she can just be complaining of, just some pelvic pressure, or maybe she's just complaining of some cramping or a backache, okay? It doesn't have to be full-blown labor like what we see with term people. But anyways, when we do a TVU, transvaginal ultrasound, her cervical length is less than 2.5 centimeters, okay? So she can have cramping, okay, I said all that stuff. Biochemical markers, so what is that? So those are actual tests that we can do. So the test that we do to predict a preterm birth or preterm labor is called a fetal fibronectin test. What is fetal fibronectin, you ask? Well, I'll tell you, okay? So it's a protein that is on the fetal membrane, so the bag of waters, that kind of is what adheres it to the uterine, the bag of waters to the uterine lining, okay? Very simple explanation. If we see any of that glue or fetal fibronectin in a vaginal swab, then so when we test for fetal fibronectin, first of all, it's a vaginal swab, okay? And if the woman her water can't be broke, because it will skew the results, but it doesn't even matter, because if her water broke, then we need to admit her for premature rupture of membranes, or premature preterm rupture of membranes. Anyways, and she can't be bleeding. She could not have had sex. I think it's 24 hours. And we cannot have done a vag exam with lubricant. Okay? Now, if the test is negative, in other words, they don't see this fetal fibronectin, then we say that she has a 1% chance of giving birth in a week. Okay? But if the test is positive, then she will likely give birth within 2 weeks. All right? So what do we do for preterm labor? Well, we try to stop the contractions. And we do that by giving what's called tocolytics. Okay, tocolytics is what we give to calm the uterus down and stop contractions. Tributaline was one of the drugs that we've given, that we give 0.25 milligrams sub-Q. It's actually a asthma medication, I think. Yeah, asthma. So it's a smooth muscle relaxant. So it relaxes the smooth muscles of the uterus. So we can give that sub-Q. The one thing that tributaline causes is increased heart rate of both mom and baby, which, you know, we don't get all up in arms about, but I do tell moms that you might feel your heart is racing. Okay, so that's kind of normal. It's not pleasant, but don't worry, you're not, your heart's not going to beat out of your chest. But when we have these people on the monitor, we might now start seeing tachycardia in our baby. So we just kind of need to tolerate that until it wears off. The other medication we give is indomethacin, which is an NSAID. So the labor process kind of resembles an inflammatory process where prostaglandins and cytokines are released. So indomethacin helps with that. So they give that in a range dose, so whatever they order. Okay. Nifedipine, which is a calcium channel blocker that we give for people with blood pressure problems. This inhibits smooth muscle activity, and that's also a range dose. And I think indomethacin, I think, is, I should have looked this up for you guys. It's not on the exam, but I think indomethacin is 20 milligrams. And nifedipine can be anywhere from 10 to 60 milligrams, I think. Mag sulfate, it's an IV drip drug. It relaxes smooth muscle. It's also has a neuroprotective benefit for the baby. We give a bolus in 20 minutes of 4 to 6 milligrams, and then we put them on a maintenance drip, an hourly drip of 2 to 6 milligrams per hour, but typically 2, period. Doctors would be hard-pressed to give any more than 2 milligrams per hour. Okay, I've seen up to 4, and I think maybe even on one patient I saw at 6, okay, but in my 20 years of OB practice, but 99% of the time it's going to be 2 milligrams per hour, okay. I'm not going to get into all the particulars right now of mag sulfate, but mag sulfate is one of those high-risk drugs, okay. Anyways, the other thing we would do is give mom corticosteroids. So typically the choice is betamethasone. Now, as I had mentioned a little earlier, that is the drug that we give to mom to get to baby. It helps baby increase their surfactant production. Surfactant is needed to increase surface tension on the alveoli so that those alveoli don't collapse when they exhale. Okay, it keeps them open. All right. Anyways, so we give this and hopes that this helps baby after delivery, because preterm labor gives birth to a preterm baby and they have trouble breathing. So the standard dose for betamethasone is 12 milligrams given IM every 24 hours with only 2 doses. So you give your first dose and then 24 hours later you give your second dose. Now, some docs like the dexamethasone. I've given it a couple of times, but the choice is betamethasone. That's 6 milligrams every 12 hours for 4 doses. So it lowers the problem with respiratory problems with baby. Also, intracranial hemorrhage, or decreases the severity of intracranial hemorrhage and necrotizing enterocolitis. The risk to mom for these medications is it just puts her at an increased risk for infection, okay? Pulmonary edema and hyperglycemia. So if this mom is a diabetic mom, and you give betamethasone, expect to see her blood sugars go up a little bit. Okay. All right. Now, a couple terms here. This is about rupture of membranes. So we either have PPROM. We either have PROM or PPROM. So PROM is the premature rupture of membranes before the onset of labor. Okay. So this could be your 38, 40 weeker. Her water broke and her labor never started. Okay. Premature rupture of membranes. That's kind of confusing because when we talk about premature, we're thinking about before term, like before 37 weeks. But it's just premature in relation to the labor. So the membranes ruptured prematurely because the labor didn't start. Okay. PPROM, on the other hand, is the preterm premature rupture of membranes. So this is a preterm baby whose water broke. Okay, so this is before 37 weeks, and again, it's in the absence of labor, or she's not laboring and contracting. Okay, risk factors, you can read those. Signs and symptoms, she could have a gush of fluid, a trickle of fluid, and it doesn't have to be continuous. It can be a little trickle, a little gush, and then not feel anything, and then maybe an hour later or 2 hours later she feels it again. Or it can be unmistakable, okay, where she's got this huge amount of fluid that she's standing in a puddle. Okay, so how do we diagnose it? We can do a sterile speculum exam and see pooling of fluid in the vagina. We can do a nitrazine test. Remember this, a nitrazine test is this little piece of paper that we slide in the vagina and try to soak up all the juices in there. If that paper turns blue, then she's probably has a rupture of membranes. Okay, so what it's telling us is it's detecting a pH of greater than 6, and that is that's indicative of amniotic fluid. Okay, but we don't do those much anymore. However, some people are still going to be tested on that, so remember. An AmniSure is the test that we're doing today, or these days. Okay, and it detects proteins. There's this fancy word for this protein. I didn't even write it down, but it detects this protein that is given off by the placenta. So we shouldn't be getting that protein from that placenta if her bag of waters is intact. If it's not intact, then that protein will leak out with the amniotic fluid, and we will detect it on this test. The other test, which we rarely ever do, I worked with a doctor in Wyoming who only did this test. It's called the Fern test. And basically what you do is you take a swab of inside the vagina, you smear it on a slide, you go put it under a microscope, and what you're looking for is a ferning pattern. So it looks like a fern laying there on your microscope, but that's the sodium chloride. Okay, so that means her water's broke. All right, so what do we do? Well, first, how many gestational age is she? Is she term? Can she just labor, or is she preterm? And if she's not laboring, can we keep her pregnant, even though her water's broke? Can we keep her pregnant for as long as we can? And yes, we will if we can. All right. So we need to assess fetal growth. We need to assess the status. The baby's, we need to put the baby on the monitor and see how the baby's doing on the monitor with its fetal heart rates. And then we need to watch the amniotic fluid volume. Now, babies will constantly produce amniotic fluid, so it's not like it's all going to drain out and be 100% gone. Babies continually produce amniotic fluid, okay? So even if she's ruptured, baby's still going to produce it. However, if she's ruptured, she's still going to drain. So we just need to make sure that we're having adequate volumes to support baby. All right. So we put these people on bed rest, IV fluids, antibiotics to prevent infection. We may even put them on mag sulfate. We'll definitely be giving mom betamethasone for the baby, and then she'll be on constant fetal monitoring because baby is going to tell us if things are going bad or not. and then we're going to watch maternal vital signs because we're worried about infection. If a mom gets a uterine infection, then baby's going to get it, okay? So we watch mom's vital signs, we watch the fetal heart rates, and if we can keep those people stable and looking good, we will keep them as pregnant as long as we can. Okay, but as soon as one of them tells us that things are going badly, then we need to start talking about delivery. All right. All right. Okay. So, all right. Now we're moving on to hypertensive disorders. Okay. So there's pre-pregnant hypertension, which is chronic hypertension, and there's pregnancy-induced hypertension, and there's a couple of different kinds. So this can be kind of confusing. So just kind of listen here and pay attention, all right? So chronic hypertension is hypertension that is diagnosed, the criteria is 140/90, all right, greater than 140/90. But this is hypertension that has been diagnosed before pregnancy. So, okay, so this is the same as the hypertension that's diagnosed in the 80-year-old man. Okay, this is just chronic hypertension. This is just plain old hypertension, all right, before pregnancy, all right? Or it's diagnosed before 20 weeks and persists past the postpartum, 84th day, oh my goodness. But just know that this is hypertension before pregnancy, okay? Now, there's preeclampsia. So preeclampsia, the blood pressure is greater than 140/90. You've taken it twice, 4 hours apart, after 20 weeks with proteinuria. Okay, so let's break that down. So she has high blood pressure, 140/90. Okay, and this high blood pressure did not start until after 20 weeks. Okay, and this high blood pressure also accompanies proteinuria. So she's spilling protein in her urine. So she has both. She has high blood pressure after 20 weeks, and she has proteinuria after 20 weeks. So proteinuria is defined as greater than 300 milligrams on a 24-hour urine sample. Okay, and it says with or without edema, because pregnant women have edema. So edema is not part of the criteria. However, you may see edema develop because of this preeclampsia. Okay, just know it's not part of the criteria for diagnosis. All right, so I'm just going to say really quick about preeclampsia, and because I think we're going to cover it, but there is a mild preeclampsia and a severe preeclampsia. So this is mild preeclampsia, what you're seeing on the screen right now. Severe preeclampsia is blood pressure is greater than 160/110, and I think the 24-hour protein is greater than 500. Okay, anyways, eclampsia is the patient has preeclampsia, but now they also have grand mal seizures. Okay, preeclampsia superimposed on chronic hypertension. Now, is that crazy? So the woman has chronic hypertension. So she had hypertension before she ever got pregnant. Okay, it's superimposed with preeclampsia because now she also has proteinuria. So we're not saying that her blood pressure was she had chronic hypertension before pregnancy and her blood pressure stabled and then she developed blood pressure again and proteinuria. She always has hypertension. Okay, she has chronic hypertension, but now we're starting to see proteinuria. All right. Thrombocytopenia and elevated liver enzymes can also be part of the diagnosis, but we'll see those with severe preeclampsia as well. Okay, so the hallmark thing here is she has chronic hypertension and now she has new onset proteinuria. All right, gestational hypertension. Oh my gosh. Okay. So gestational hypertension is she doesn't have chronic hypertension, but she does have a little bit of an elevated blood pressure, but she has no proteinuria. Okay, so it's not preeclampsia, it's not chronic, it's just gestational. So she just has elevated blood pressures when she's pregnant. Okay, nothing else. And then this stupid transient is she has gestational hypertension with no proteinuria, and it continues for about 12 weeks postpartum. Okay. So don't get real crazy about the transient, okay? Just know the difference between chronic preeclampsia and gestational hypertension, okay? I do want you to know that eeclampsia is with the seizures, and then if you know what chronic is and you know what preeclampsia is, then you know that preeclampsia is superimposed on chronic hypertension is she has chronic hypertension and now a new onset proteinuria, okay? Wow. All right, so preeclampsia, it's a multi-system disorder, a vasopressive process, okay, that targets the cardiovascular, the hematologic, the hepatic, so the liver, the renal, so the kidneys, and the central nervous system, so the level of consciousness and or seizures, okay? It's a progressive disease. So why does it happen? So they basically call it a disease of the placenta, okay? And the reason why they do that, because after baby's born and the placenta is delivered, they get so much better, although they can still be a little bit sick. Anyways, so what there's the other reason is because the trophoblast cells. So we haven't gone over this, but remember I said the trophoblast cells are what develop into the placenta, okay? So for some reason, those trophoblast cells do not completely transform the uterine spiral arteries, okay? So the trophoblastic cells, and then developing in the placenta, they invade the myometrium and get implanted, and then the uterine spiral arteries, they transform those so that they can start feeding the placenta, okay? So that doesn't happen perfectly, all right? And then those spiral arteries develop what they call acute atherosis, which is fat accumulation in the arteries, and parts of the placenta form an infarct because those uterine spiral arteries aren't working great, okay? So these changes lead to decreased placental perfusion. So who else is having decreased? So the baby is having decreased oxygenation, okay? So here we're going to break it down a little bit or add additionally. So in preeclampsia, what happens, or something that's going on with preeclampsia is we have vasospasms of the vessels and endothelial cell damage, okay? Now, the vasospasm, of course, you know, if you've got those vessels spasming, then we're going to cause an elevation in arterial pressure because the heart's trying to push against that vasospasm, okay? So that creates a resistance to blood flow. Now, do we have the vasospasm because of the damage to the vessels, or do we have the damage to the vessels because of the vasospasms? Who knows? We don't know which way it goes, okay? But we do know we have vasospasm, we have vessel damage, and that increases our blood pressure, okay? That vasospasm causes restriction of blood flow, like I said, and then the endothelial damage, so that's damage, so that's inflammation and damage, which prompts the inflammation reaction in our body, which causes us to use platelets and fibrinogen. So just think of, you know, you slicing your arm and those products coming to clot off the blood. So we have endothelial damage, and then so therefore the platelets and fibrinogen are going to be activated. Now, because of this restriction in blood flow and the platelets and the fibrinogen activity, we're decreasing our blood flow, are causing a blood flow resistance. So now we're going to have hypoxic damage to our organs that are so depending on good blood flow and oxygenation, okay? So it's going to start damaging our organs. So that's why we look at patients with preeclampsia, that's why we're looking at their kidney function. That's why we're looking at their liver function, and that's why we're looking at their brain function, okay? Activation of clot cascade. So, okay, so that's kind of more of an explanation there. Now, in addition to those things going on, pregnant women, no, I'm sorry, not pregnant women. people who have preeclampsia have an exaggerated response to angiotensin 2. Remember, angiotensin 2 is what helps elevate our blood pressure. Okay, so that kicks in like when we're hypovolemic and our blood pressure drops, so angiotensin 2 kicks in. Well, people with preeclampsia have an exaggerated response to angiotensin. Okay, so therefore, we're going to see more exaggerated high blood pressures, I guess is a good way to say that. So normally in pregnancy, our response to angiotensin is blunted. Therefore, our blood pressures are usually a little bit lower during pregnancy, but in preeclampsia, it's exaggerated, so we're seeing more of a response. Okay, so remember, angiotensin 2 is produced by the renin-aldosterone system. You know, the renin comes in, gets the angiotensinogen, and then the angiotensin converting enzyme changes it to, from angiotensin 1 to angiotensin 2, and so angiotensin 2 is a vasoconstrictor, and it triggers hypertension, basically. So there's an exaggerated response to that. Plus, there's an exaggerated response to other pressors, and a low, and normally there's a low sensitivity, just like with the angiotensin. So the other thing that's also happening in addition to those other things is we have an imbalance between prostacyclin and thromboxane. So prostacyclin is a prostaglandin, but the important thing about it is it's a potent vasodilator. Okay, so it vasodilates us. And then the thromboxane is it's synthesized by the platelets from prostaglandins, and it exerts it has a vasoconstrictive effect. Okay, so prostacyclin, it relaxes smooth muscles, decreases blood pressure, prevents platelet aggregation, which then promotes uterine blood flow. Now, there's an imbalance in preeclampsia where there's not enough prostacyclin circulating around to do these things. And then the thromboxane, which is the vasoconstrictor, its presence is increased. So the prostacyclin, which is supposed to lower our blood pressure, you know, there's not a lot of that around to do that. And then thromboxane, which is a vasoconstrictor, there's an increased response from that. So then we get also the vasoconstriction, which increases our blood pressure. So it's a really ugly process, kind of confusing. I'm not breaking this down in the exam, but it's good to know this pathophysiology. Okay. So there's a funny little mnemonic that you can think of to try to remember all this stuff about preeclampsia. So the S is significant blood pressure change. The P is proteinuria. Okay. The A stands for the arterial vasospasms. Okay, resulting in endothelial damage or vice versa. When we have endothelial damage, we have leakage of intravascular fluid into the interstitial, which is why you sometimes see edema. But remember, edema is not a criteria for diagnosis. Sorry. The S is for significant lab changes. So we'll see changes in our liver function, our kidney function, and our platelet levels. Okay. M is multi-organ involvement. So we have our liver involvement, we have our renal involvement, we have our central nervous system involvement, cardiovascular, hematologic involvement. Okay. And the symptoms, the last S is after 20 weeks. So I don't know if that was helpful or not, but there it is. This is a little schematic diagram for you to see what the effects of preeclampsia are. So you can go through this, and this may be helpful for you to remember things. I do want to point out, okay, so when we start here with our decreased placental perfusion, we have our vasospasms and our endothelial damage, okay? From there, we have, we talked about the thromboxane and the prostacycline, okay, which we react to one, don't react to the other, so we have an increase in our blood pressure. Because of the endothelial damage, we have fluid shifts from the intravascular to the intracellular or interstitial tissues, and then we have intravascular coagulation, remember, because we have the endothelial damage, and so that's going to start our response. It's supposed to be our salvation, but in this case it's not saving us. All right, now then those things are happening. Okay, then we come up here, and because of all of this and the high blood pressure and the endothelial damage and the vasospasms, we start developing uteroplacental lesions in the arterioles. Okay, we start having glomerular damage, so we're having kidney problems, so our filtration, glomerular filtration. We start having the edema because of the endothelial damage and the fluid leaking out. Cortical brain spasm, so we start having reactions in our brain. We start having pulmonary edema because of the fluid shift. We can have vision problems. We start lysing our red blood cells. We start having hepatic or liver problems. We start having more platelet aggregation and fibrin work, okay? And so each one of these we'll start seeing. So come back to the top again, uteroplacental lesions. So that means we're having problems with our placenta. It's not getting oxygenated oxygen to our baby, so we're having intrauterine growth restriction. We're damaging the uteroplacental vessels, so we might have an abruption, and which is also causing increased contractility. With our kidney damage, so that's why we're seeing proteinuria, because we're damaging the glomerular filtration. Increased plasma uric acid and creatinine, so we're retaining this, we're not excreting this, and then we're reabsorbing it back into the bloodstream, so we can do a blood test to check the levels of uric acid and creatinine. Oliguria, so we're decreasing our urine output because we're decreasing our, we're having problems with our vasculature, okay? And then increased sodium retention, which is then going to also continue to cause us problems with edema, generalized edema, okay? So with our brain, we can have headaches, hyperreflexia, so that's when you do your DTRs, deep tendon reflexes, and the woman kicks herself in the forehead because of hyperreflexia. And then she could have seizure activity, which would be uroclampsia. Pulmonary edema is going to cause shortness of breath, problems to the eyes, so she's going to start having blurred vision or spots in her vision. So we assess that. Red blood cell breakdown, so decreased hemoglobin, decreased oxygen binding capability, and increased maternal hyperbilirubinemia. Okay, the liver problems, so we're going to see elevated liver enzymes. So ALT and AST are two labs that we commonly look at to see how our liver is functioning. She might have nausea and vomiting because of it. Right upper gastric pain, that's something we assess for as well, so that will tell us liver involvement, or right upper quadrant pain. Decreased blood glucose, possibly even a liver rupture. That's really super bad. And then we look at the platelets. So we said, you know, we have this endothelial damage. We activate our platelet aggregation cascade, and then so we will see a low platelet count or thrombocytopenia. So we look at the woman's platelet count. Is it dropping? Okay, and that's implying worsening of this disease. And then as we start using up our clotting factors, then DIC, disseminated intravascular coagulation, starts to occur. So that's when you use up all your blood clotting products, and you continue to try to clot, and you continue to try to make clotting products, and you continue to try to clot, but they're immature, and so you have this microclotting and bleeding at the same time. Okay, wow, that sounded crazy in my head, and I know this stuff. So like I said, guys, please call me if you have questions before the exam. Okay, risk factors. You can look at the risk factors on page 354. However, I'm not testing you on risk factors. So what do we do? So remember, I said one of the placental problems is if you deliver the placenta, you've cured the disease. Well, that's pretty correct. However, some women can have signs of preeclampsia up to 24 hours after delivery. Anyways, so preeclampsia without severe features. So their blood pressure is 140/90. They are spilling a little bit of protein. They might have a little bit of edema. So it's conservative management. So, diet, hydration, and actually diet doesn't really do anything for their blood pressure, but, we do whatever we can. Diet and hydration, rest on left lateral side. So just remember, left side is the gold standard for putting a pregnant patient. However, if you do the left side and that's not good, then you do the right side. You keep trying different positions, but the left side is the side because it gets the weight of the uterus off the vena cava. We'll watch her labs and to see how it's progressing. This is a progressive disease. It can progress quickly or it can progress very slowly. Okay, but anyways, we'll watch her labs to see watch that progression, and then we'll watch our baby to see how our baby's tolerating things. Remember, all that vasospasm and all those problems with the vessels and stuff with the placenta and the uterus, so baby's not getting the oxygenation that they need. So depending on how well the baby's doing and how well the baby's tolerating this, we might continue to let this person be pregnant. But if the baby is doing bad, then we might need to decide to deliver. Now, preeclampsia with severe features, or severe preeclampsia, is a blood pressure greater than 160/110. She's having increasing proteinuria. The disease is progressing, so she's now starting to have visual problems. She's now starting to have that epigastric pain. She's having nausea and vomiting. She may even be bleeding. So remember, we're activating that clotting system, but we're using up her platelets, so things start to bleed. Like she could be bleeding from her gums. She might get a nosebleed. She might be bleeding from old cuts or things like that. Okay, we're starting to involve her CNS, so she's having headaches. We might see increasing edema. So we're now having kidney involvement. So we're seeing decreased urine output, and then eventually, at some point, the baby is going to start saying, like, I can't deal with this. And so we're going to see decreased fetal movement. So baby is trying to conserve everything and only do what it has to do because it's having trouble oxygenating. Okay. And then if your woman comes in with high blood pressure and no other symptoms than, boy, I'm just feeling really weird, then I would panic just as much if she had every one of these symptoms. Because I had a patient just like this. She had elevated blood pressures, no other signs and symptoms. She said, I just feel weird. And then within 5 minutes, she was having a grand mal seizure. So preeclampsia can be a pretty bone-chilling thing. All right, moving on. Now, we hospitalize these patients and we decide whether or not we need to do delivery now or whether or not we can wait. Can we do a vaginal delivery or do we need to move to C-section? So we put them on the fetal monitor. Everybody gets put on the fetal monitor. Just about everybody gets an IV with IV fluids of lactated ringers. Of course, we're going to monitor mom's vital signs and oxygen saturations and then put in an indwelling Foley catheter. Remember, anytime you're having problems with the kidneys, you need a catheter, okay, because you need to do strict I&O or strict urinary output measurements, okay? We're going to be doing frequent nursing assessments. We're going to do a 24-hour urine collection. We're going to do CBC. We're going to look at her electrolytes. We're going to look at her liver function studies and her kidney function studies, okay? We will put this woman on mag sulfate only to prevent seizures. A side effect of mag sulfate is hypotension, so hopefully that side effect kicks in. But the reason why we give mag sulfate is to prevent seizures. Okay, we might give antihypertensives to reduce her blood pressure. And then let me just look real quick. Oh crap, I didn't bring my textbook in. I can't remember what's on page 356 and 357. It might be antihypertensive medications we use. So take a look at that. Anyways, mag sulfate is a high alert drug. It is very easily and very quickly becomes toxic. And so what that means is very quickly, look at the bottom, cardiac arrest. Okay, so this drug takes 2 nurses to hang and adjust rates because of its toxicity. We can monitor serum magnesium levels, or we can do vigilant nursing assessments. Now, so let's talk about mag levels. So if you get a mag level back of 1.5 to 2 milliequivalents per liter, that's a normal range, okay, for an adult. But if you're a pregnant woman on mag sulfate, your therapeutic range is 4 to 7. So I have very often sent down mag levels to the lab, and they would call me with a critical high of 5 or 6. Okay, so for a normal adult, yes, that is a critical high, but for a pregnant patient with preeclampsia, that is the therapeutic range in which we want her in, 4 to 7 milliequivalents. Okay, now when we do our assessments, now we don't typically do ECGs on pregnant patients as far as our vigilant assessments for mag sulfate administration, but we would see ECG changes between 5 and 10 milliequivalents. Okay, what we do look at is reflexes. So we do deep tendon reflexes on the knee, a frequent assessment, and if we lose those reflexes, if we have no deep tendon reflexes, then we know that our mag level is anywhere between 8 to 12 milliequivalents, and that's too high. You see, our therapeutic range is 4 to 7. If we start having respiratory distress, then we know our mag level is 15 or more milliequivalents. Okay, and then of course if we have cardiac arrest, then our mag level is probably 25 or more. Okay, so do frequent assessments, look at your reflexes, monitor your woman's respiratory status, oxygen saturation, monitor her level of consciousness. I'm not sure when she starts losing LOC. It's somewhere between 15 to 25 milliequivalents. Okay, so if you're starting to see those things, then we've got a problem. Okay, so we have our hypertension, which we know what those parameters are, 140/90, or if it's severe, it's 160/110. Proteinuria is more than 300 milligrams in a 24-hour urine test, or if we just do a dipstick urine, it will equal 1+ on the dipstick. Okay, urine output we assess every 1 to 4 hours, just so that we can watch kidney function. We want her urine output to be greater than 30 cc's an hour, or greater than 100 cc's in a 4-hour period. We'll assess for edema, but we might see it. But if you're listening to lung sounds and you're hearing adventitious lung sounds, then we probably are having a pulmonary edema, which is not good. Okay, CNS alterations. So the patient might complain of a headache. She might complain of visual disturbances, blurred vision, spots in her vision. And so if she's having CNS problems, then we've got a pretty severe preeclampsia going on, and she might have start having seizures. Okay, when we assess DTRs, you know, they're 1 to 4+. So 1 is what do they call that? 1 is a low deep tendon reflex, which is okay. 2 is a normal deep tendon reflex. 3+ is brisk, and 4+ is, I can't remember what they call it, but it's really, this is where she's kicking herself in the head. Okay, and then we also assess clonus. Clonus is going to tell us about her CNS status. Clonus is when you dorsiflex the foot, and if the foot bounces, that is clonus. Okay, so normally it's absent. There's no bouncing. But if it's present, you count the number of beats. Okay, and then we assess her level of consciousness, of course. All right, so remember, eclampsia is grand mal seizures. They will have hypertension, proteinuria. They'll probably have edema. They'll have extremely brisk reflexes. Their clonus can be mild to severe. No proteinuria, no edema, normal reflexes. So she could have grand mal seizures even when she's not showing signs and symptoms. Okay, so that's why eclampsia is, or preeclampsia is so bone chilling. Okay, complications: cerebral hemorrhage, aspiration pneumonia, hypoxic encephalopathy, coma, a thrombolytic event, death. Okay. When she does have a seizure, usually they're self-limiting. In other words, she'll have the seizure and it'll stop. Okay. The patient that I had, the one patient that I had in my whole career that had a seizure, we pushed MAG on her, we pushed Valium on her, and we could not stop the seizure. And she did not stop seizing until we got her in the OR and got anesthesia on board. So that being said, they're self-limiting, right? So anyways, really scary stuff. Now, HELLP syndrome is when they have preeclampsia. They don't necessarily have had a seizure, but the disease has progressed, and they start having hemolysis. We'll see elevated liver enzymes, and we'll see a low platelet count. So you take those highlighted letters, and that stands for HELLP syndrome. Okay. It is a complication of severe preeclampsia. However, depending on progression, your patient may only have a mild preeclampsia and then rapidly progress to HELLP syndrome. Okay, so she has the hemolysis due to that those constricted spasming vessels. Those constricted vessels, those vasospasms, is going to decrease blood flow to the liver, which is why you're going to see the elevated liver enzymes. And then the low platelet count is because they're utilizing their platelets because of the vasospasm and the endothelial damage. When they have the liver involvement, they'll be complaining of right upper quadrant pain or epigastric pain. They will complain of just not feeling well, like flu-like symptoms. They may have nausea and vomiting, and a headache, shoulder pain, bruising, bleeding, any one of all those things. So the treatment for a patient with HELLP syndrome is to maybe provide platelets and or fresh frozen plasma and deliver the baby ASAP. Okay, because this is a progressive disease. This is not going to get better. Okay, she's having HELLP syndrome. Mom is severely compromised. It's going to continue to be compromised. It's going to continue to get worse. So we got to get baby out of there. All right. Now, a further complication is disseminated intravascular coagulation, or DIC. So again, this is a clotting disorder that is diffuse, profuse, and systemic. Okay, so they're consuming a large amount of their clotting factors, which causes external and internal bleeding, but they're going to constantly keep trying to clot because you're constantly bleeding. Okay, so this is just a progressive clotting and bleeding. Okay, so we'll be placing a catheter, we're getting oxygen on, we're pumping in blood products. This is a very bad DIC. This is not exclusive to pregnancy either. This could be anybody who's having some sort of massive bleed. But this can be deadly. Okay, so we've got to get the clotting under control. We've got to get the bleeding under control. All right, I'm going to take a really quick break. All right, I'll be back in just one sec. Okay, wow, I just saw that I'm almost an hour and a half in, and I'm only halfway through this this chapter, and I still got to do the next one, so I'm going to hurry it up a little bit. I know there's a question about twins, I think, on the exam, so this is what multiple gestation is about. So 2 or more fetuses, so there could be 3, 4, 5, 6 in there, but usually we're talking about twins here, 2 babies. So there's 2 different types of multiple twins. Is the fraternal, or what they call dizygotic twins, or there is the identical, which is the monozygotic twins. Let's go back to fraternal, which is dizygotic, okay? Let's break that word down. Di. What does di mean? It means 2. And what does zygotic mean? Zygote is a fertilized egg. Okay? So it's just a fertilized egg. So we have 2 fertilized eggs. That's a fraternal twin. They're 2 separate eggs that have been fertilized. 2 separate ones. Just like if you got pregnant in 2010, there's that egg with that pregnancy. And then say you got pregnant in 2012, there's that egg and that pregnancy. Okay? So a dizygotic or fraternal twins, those twins are as different as the baby you were pregnant with in 2010 and 2012. They're totally not the same babies. 2 whole separate eggs that have been fertilized. There are 2 completely different people in there. Just like the baby that you were pregnant with in 2010 and the baby you were pregnant with in 2012. Okay? So it could be 2 girls in there, it could be 2 boys in there, it could be a girl in there, and it could be a boy in there. Okay? So that's what fraternal twins are. They're dizygotic twins. 2 eggs. Now the confusing one, which is the identical twin, are monozygotic twins. So monozygotic, so let's break that word down. Mono meaning 1, zygotic meaning zygote or fertilized egg. There's only 1 fertilized egg, okay? And that 1 fertilized egg splits and makes 2 separate fetuses, okay? These fetuses are identical because they came from 1 single egg, okay? Now the reason why these are confusing is because depending on when that split occurred in the after fertilization will means different things as far as those twins are concerned. Okay, they're still identical. They're still from the single egg. Okay, so let's look at what that means. Okay, there's the dichorionic, diamniotic. Now we haven't learned really what chorionic or amniotic mean, but I'm just going to tell you. That is the membranes that surround the baby. Okay? Why is that important? There are 2 membranes that surround the baby that actually really kind of make up one membrane. Okay? There's 2 membranes that are so close together, like there's really not any space in between them. They're kind of fused to one another, but they're 2 distinct membranes. But when we talk about rupture of membranes or your bag of waters, that bag or those membranes, there are actually 2 of them, okay, but we refer to them as just being 1, okay? So, there's the chorionic membrane and the amniotic membrane. And so when we talk about dichorionic, diamniotic, we're talking about 2 chorions and 2 amnions, okay? So the chorion is what develops, the trophoblastic cells develop into the chorion and the placenta, okay? So we're talking about the outer membrane and the inner membrane, okay? So there's 2 of the chorions and 2 of the amnions, okay? And so usually there's 2 placentas. But if there's 1 placenta, it's usually because the 2 placentas have fused, okay? So that division takes place very quickly after fertilization. So usually during the first 3 days of development, okay, that split occurs. Okay, the chorion and the amnion have not completely developed. So when that split happens, then that's why when that split happens, that those 2 partial developments then create 2 separate developments. Okay, and 2 fetuses. So also I'll let you know that the amnion develops faster than the chorion. Okay, so anyways, So there's the dichorionic and diamniotic. You got two amnions, you got two chorions, you got two placentas, and if you're going to have monozygotic twins, you're going to kind of hope that you have what we call the di-di dynamic, because there's better outcomes for these twins. Now, the other one is the monochorionic diamniotic. Okay, so what happens is there's one chorion membrane, there's two amniotic membranes or amnions, all right? And because there's one chorionic membrane, the chorionic membrane develops from the trophoblastic cells that also form the placenta. So if there's one of those, there's one placenta, okay? So you have one chorion, two amnions, all right? So you've got two little sacs inside one big sac, all right? This division takes place about 4 to 8 days, okay? The so the next one is the monochorionic monoamniotic. So that's that's one chorion, that's one amnion, and this division occurs later after the first week, okay? So you've got two babies inside of one sac, and then the other sac, so you've got two babies in one sac, okay? They share the placenta. This is the most dangerous for the baby, as far as I mean, if you have a mono twin situation, these babies can be born without any problems, but these do have the most problems. All right, so how often does the one happen or the other? Okay, so dizygotic twins, okay, so di meaning two, zygote meaning fertilized eggs, so you have the two separate eggs that were fertilized, okay, so those tend to run in families, and those are usually 70% of your twin babies, okay, and then the monozygotic, where the one egg splits, that's about 30%. So what are the complications? So of course, if you have two big old babies in there, that's going to put pressure on the pregnancy, which may cause preterm labor. Moms may have developed gestational diabetes. They have increased urinary tract infections because of the pressure of the uterus on either the bladder or the ureters or the urethra, okay? Anemia, so you can read through all these, all right? Those are the complications for a woman, okay? Oh, and the baby. So I do want to hit those. So fetal intrauterine growth restriction. So these babies are smaller than they should be because there's more of them, and you know, they need to get their nutrition from mom. So they're both not just getting enough. Okay. Abnormal presentation. Usually one's head down, one's head up. Umbilical cord prolapse, because you know, when you have two fetuses in there, they create this pool in the center of the uterus, center bottom of the uterus. So the cord usually just sits there, so when the water breaks, the cord just follows through, okay? And then twin to twin transfusion. So this is the problem. One of the big problems is, so if you have one placenta and two babies hooked up to it, and the blood is pumping through the cord, through the placenta, back to the cord, to the baby, back to through the cord, to the placenta, and back and forth and back and forth. Well, sometimes what happens is they're both pumping blood, you know, to the cord, and then they're both getting blood back, but for some reason the one twin gets his share and the other half of the other twin's share. Okay, so that's twin to twin transfusion. So the one twin is getting I'm just saying 1.5 times because I'm just making the number easier. I don't know how much as far as the different level of blood back and forth, but the one twin is getting 1.5 times the blood, and the other twin is only getting half the blood. Okay, so so that twin to twin transfusion, we call the one twin that is getting the least amount of blood to be the donor. Okay, so as his blood is pumping to the placenta to drop off waste and then get pumped back to him, he's getting a very smaller supply. In other words, he's giving up some of his, so he's the donor twin. And then the recipient twin, of course, is the one who's getting the bulk of the blood flow. So this could be very dangerous for the donor twin as well as the recipient twin, because there could be some other problems that are going on. So how do we diagnose this? Well, ultrasound reveals that there's more than one baby in there. Okay. We have the rapid growth of the mom's belly. She has an increased weight gain. And if we do a Leopold's maneuver, we can palpate more than we should be palpating for one baby. So she would have elevated HCG levels, placental lactogen levels, and maternal serum alpha fetoprotein levels, okay, just because she's got more babies in there. So how do we diagnose chorionicity, or how many membranes are going on? So we can do an ultrasound at 10 to 13 weeks, and then they can see the presence of placental tissues between the layers, and or the absence of the placental tissue between the layers, okay? So as far as management, we'll be doing antenatal surveillance often, and then when we decide that the pregnancy is at risk or the babies are at risk, then she gets hospitalization. And delivery at a level 3 facility, it just depends on the hospital's protocol, but usually the higher level of care is better, because typically we might see problems with babies, especially if they're delivered early or small for gestational age, or intrauterine growth restriction. So a facility, like if you had twins, so it'd be better to deliver at community as opposed to St. Pat's. And I'm trying to think of the policy at St. Pat's. I worked there, but now I can't remember if they'll deliver twins or not. But anyways. Okay, so enough of multiple gestation. Please let me know if you have any questions. That was kind of confusing. Now, I'm not going to talk about these infections. These are maternal infections, except to say that the UTI is the most common maternal infection that we see, and it is the most common reason for premature contractions. So you cure the UTI, you've settled down the premature contractions. So a lot of times these women come in with asymptomatic bacteria, so they really don't feel like the signs and symptoms of a UTI, but they come in because they're contracting. Okay, so we'll hydrate them, we'll check a urine, and we'll find out that they have a urinary tract infection. So we treat them, and then all's good. Okay, but you can go through, you can look through these. I will look to see for certain if I have questions about. I don't think I have any questions about infections in pregnancy, but please look over these, okay? At least be aware of them. The one I am going to put out is group beta strep infection. So GBS is what you'll hear it called, GBS. So that's a normal vaginal and fecal flora, and it doesn't cause the woman any problems, okay? However, if the baby is born through a vagina that is infected with GBS, which again does not hurt mom at all, the babies can contract that infection and become septic very quickly. So we test all pregnant women at 35 to 37-ish weeks to see what their group B strep status is, and if they are positive for group B strep, then we treat them with antibiotics in their labor. And it's not to actually treat the infection. It is to prevent the baby. It's for the baby, prophylaxis for the baby, to treat the baby, to prevent baby from becoming infected. So we treat moms who are positive, and we treat moms who we don't have a GBS result on. Okay, so then we just assume she is positive and we treat her. It's not going to hurt her or baby to be treated, okay? But it will hurt baby to not be treated if this woman was indeed positive. And we treat with penicillin, and if they have a penicillin allergy, we'll use clindamycin. Okay, so just read about the torch. The torch is different infections, than they've made the pneumonic torch. We like to know mom's hepatitis B status. We like to know her syphilis status. We like to know her HIV status and her rubella status. And of course, we want to know her herpes simplex virus status. Look through these pages to look over these infections and how they affect mom and babe. But if a patient has an active herpes, if she has active herpes lesions on her vagina, then she is not allowed to have a vaginal delivery. Okay, but if she does not have active lesions, she can have a vaginal delivery. Okay, you can read about all the other STIs, HIV. You can read about that. Tuberculosis, lupus, sickle cell disease. You can read about that. Okay, this is where I want to pick up. RH isoimmunization. So RH, we are either RH positive or we are RH negative. I'm going to try to go through this quickly, so if I go too fast, if you end up confused, please call me. We'll talk about this, okay? But I want you to understand this. RH, so we have a mother who is RH negative. She could be, her ABO can be A, O, AB, but that's not what we're talking about here. We're talking about her RH status. Does she have the, I forget the word for rhesus antigen on her red blood cells? If she does, she's positive. If she doesn't, she's negative, okay? So RH negative mother and an RH positive fetus is where we have the problem, okay? So follow me here. So in her very first pregnancy, okay? No, let's not even talk about pregnancy. An RH negative mother or person can be exposed to RH positive blood through a blood transfusion, or she could have had a previous abortion or something like that. So if an RH positive mother is exposed to, if an RH negative mother is exposed to RH positive blood, like in a transfusion, then her blood is going to see those positive RHs on those blood cells, and her blood is going to create antibodies to go kill that RH positive stuff, okay? And so she's killed it, okay, and that's all there is to it. But if she becomes pregnant for her very first time, and she was exposed to RH positive blood through a transfusion, she has those antibodies in her body, and those antibodies can cross the placenta, and they will go after the baby if the baby is RH positive, and they will kill the baby's RH positive blood, okay? That's isoimmunization or alloimmunization, okay? But that's if mother was exposed somehow through a blood transfusion. Now, we have a mother who's pregnant for the first time. She's RH negative. She has a baby, and we don't know if that baby is RH positive or not, okay? So wonder if she has an abortion or a miscarriage and somehow is exposed to baby's blood at that point, and that baby happens to be RH positive. She will create antibodies to that RH positive blood and defeat them, okay? So that is why if we have a woman who has a spontaneous abortion or a miscarriage and she's RH negative, we will give her RhoGAM. RhoGAM will prevent her from developing antibodies because we don't know what that fetus was, and we're not going to take the chance that it was a RH positive fetus, okay? All right, so if an RH negative mother is pregnant and she has some sort of invasive procedure, if she had a bleed from a placental previa or abruption, and she was exposed to baby's blood during those procedures, or if she was in a car accident and had abdominal trauma, just anything that causes a trauma or causes her to be exposed to baby's blood in some way, shape, or form, which doesn't happen in a normal, untampered with pregnancy. It's a tampered with, where we do an invasive procedure, or she's had a trauma, or she's had a bleed, or something, where she might be exposed to baby's blood. And if baby's blood is positive, mom's blood will create antibodies to kill those positive bloods, okay? So, if mom has an invasive procedure in while she's pregnant and she's Rh negative, we're going to give her RhoGAM because we don't know if she will be exposed to baby's blood or not. She may not, okay? But if she is, she will create antibodies, and those antibodies will cross the placenta and attack the fetus. So if she has an invasive procedure or some sort of trauma, we will give her RhoGAM to prevent her from creating those antibodies. Everybody's good, okay? All right. So, one of the things we do when we find out we have an Rh negative mom is we can do an indirect Coombs test on mom. And that detects whether or not she has antibodies to Rh, to rhesus negative antigens, okay? So the indirect Coombs, if it's positive, she does have antibodies. If it's negative, she does not have antibodies, okay? If it's negative, she has no antibodies, we rescreen her at 28 weeks, okay? And then we will give her, if she has not created any antibodies by 28 weeks, we will give her RhoGAM. And that will prevent her from developing any antibodies. And that usually lasts about 3 months, which usually is about delivery time. Okay? So specifically how RhoGAM works is it works by coating and destroying the fetal red blood cells. So mom's blood does not see those Rh positive antigens, and she does not create antibodies. Okay? So we've got to that point, 28 weeks. We've given her RhoGAM. It lasts for about 3 months, and now she's at term and she's delivering her baby. If the baby is delivered, when the baby is delivered, we will test the baby's blood. If the baby is positive, okay, the lab will do what's called a Kleihara-Becky test to estimate the number of fetal red blood cells in maternal circulation. Okay, depending on the result of that, that will tell them and or us how much RhoGAM to give her. And usually we just give 1 vial of RhoGAM. Okay, so we're counting on lab to tell us that the one vial of RhoGAM is sufficient. And I've only ever given 1 vial, so I'm not saying that 2 vials have not been given to a woman. I'm just saying in my 20 years, I've only given 1 vial, okay? And it must be given within 72 hours of the birth. Otherwise, that has given mom time to create antibodies, okay? All right. So you got that. This is if the mom is Rh negative, her indirect Coombs is negative. That means she doesn't create antibodies. She gets RhoGAM at 28 weeks. And then we do it all again at delivery, and they determine how, if there is any fetal blood cells circulating in maternal circulation, will depend on how much RhoGAM we give her, and usually it's just 1 vial. So she gets another vial at delivery if baby is Rh positive, and it must be given within 72 hours. Now, we've got an Rh negative mom who gets an indirect Coombs test. It tells us whether or not she's created antibodies. If that indirect Coombs test is positive, that means antibodies are sensitive. That means antibodies are present, and she has been sensitized. And so there is alloimmunization. Okay, so there has been mom has created antibodies. So what happens in that case? Well, we repeat that indirect Coombs frequently throughout the test to determine how high it's rising. Okay, so the more it's rising, the more antibodies she's creating, the more antibodies that are going to cross the placenta and get the baby. Okay, we can do an amniocentesis and look at what we call optical density of the amniotic fluid. And optical density increases with increasing amounts of bilirubin. Bilirubin is the product of red blood cell breakdown. So If we're having lots of red blood cell breakdown, that means that baby's blood cells are being attacked by mom's antibodies. Those blood cells are broken down, and the byproduct from that is bilirubin, and we will see increasing bilirubin in the amniotic fluid if that is occurring. Okay? So if the optical density is low, then we can say that either we have a baby who's Rh negative, so that means there's no blood cell breakdown because those antibodies that are crossing the placenta have nothing to attack because mom is negative, baby's negative. Okay, so if the optical density is low, we can think that maybe the baby is Rh negative, or the baby is Rh positive, but there is not a lot of hemolysis going on. In other words, there's not a lot of antibodies attacking baby's blood cells because there's not a lot of bilirubin that is causing, you know what I'm saying? Okay, so we just keep watching this. If the optical density is elevated, that means there's lots of bilirubin in there, then we know the baby's experiencing hemolysis. The mother's antibodies are crossing the placenta and attacking baby's red blood cells, and that baby is in jeopardy. Whew. Okay, so red blood cell deficiency in the baby, fetal bilirubins rise, which is when fetal bilirubins rise, it's called icterus gravis. Okay. If that bilirubin rises so much that we start hurting the baby's neurological system and start having severe neurological disease in the baby, that's called bilirubin encephalopathy or brain damage. That's irreversible. Okay. So what happens when baby has a lot of red blood cell breakdown? This triggers a rapid production in erythroblasts. So baby's trying to produce red blood cells, but they're doing it so fast that the blood cells that they are producing are immature. These immature red blood cells are not able to carry oxygen. Okay, so this little scenario is called erythroblastosis fetalis. Okay, then baby has fetal anemia, right? Can you imagine? Yes. And starts having a generalized edema, which is called hydrops fetalis. All right, and then we have fetal congestive heart failure. Okay, so this is really, really bad juju. So how do we know if baby's having hemolysis besides the fact that we did the optical density on the amniotic fluid? Well, we can do an ultrasound to assess for fetal anemia. So what we would see is we would see edema, ascites, an enlarged heart, and a hydramnios, which is too much amniotic fluid. Okay, we can do what's called a percutaneous umbilical blood sample, and then we could actually do a quantitative analysis of fetal hemolysis. We can, and then so if we determine these things are happening to baby, we can do an intrauterine blood transfusion for the baby. Okay, so we have done these at CMC. Really super cool. Anyways, if we can get you in on some, that would be great. All right, so that's Rh incompatibility. Please call me if you are confused. Now, ABO incompatibilities, they're really actually quite mild, but they happen when the mother is ABO type O, so they're carrying no antigens on their O blood cells. Mothers carry the anti-A and the anti-B antibodies. So if baby is blood group A or B, they are carrying, A carries A antigens, the B carries B antigens. Okay, so so that's where the problem would occur if baby was AB and mother was O. Now, A or B. Or AB. No, I'm sorry. Um, A or B. Yeah, baby is blood group A or B. Okay, so we'll do a direct Coombs test to identify if there is maternal antibodies in the newborn's blood, and we do the indirect Coombs test to identify if there is, if mom is creating antibodies. Okay, and so they're actually, oh my God, they're actually quite mild. Some places don't even test for ABO incompatibilities. If we do actually have an incompatibility, we might see a little jaundice in the baby, pretty mild, but self-limiting. We don't even treat it or do anything about it. We don't give mom anything. We don't give babe anything. We just wait till it resolves, and usually it resolves. Now, if it doesn't resolve, baby gets a little jaundice, might need some Billy Lights to treat their jaundice, but we'll talk about Billy Lights and jaundice at another time. All right, so I'm not going to go into respiratory problems for mom, but just know that if mom is having problems breathing, guess what? Baby has problems oxygenating, okay? If mom isn't able to get oxygen to the placenta, then baby's going to have problems with growth and development and things like that. Low birth weight, things like that, okay? Cystic fibrosis, another problem. We do test, I think they routinely test both parents for cystic fibrosis. Well, if the mother has it, then they'll try to test father if possible. But if mom has it, they don't worry about it because it's a recessive disorder where both parents have to have the cystic fibrosis gene in order to pass it to their child. Okay, so you can read up on that. Cardiovascular disorders, you can read up on these. I'm not going to go through this. Just know that if mom has a heart problem, what is her cardiac output? Is she able to supply the placenta, uteroplacental unit? Is it too much stress on her heart? Is labor too much stress on mom's heart? Is pushing too much stress on mom's heart? So depending on the level of heart disease, may buy this patient a ticket to more frequent assessments and doctor visits, okay? So here's a bunch of different heart diseases that mom could possibly have. They're graded, class 1, 2, 3, or 4. Women whose heart problem is graded 1 or 2, they probably won't have any problems with pregnancy or labor, but women with whose graded heart problems are 3 or 4, these women can have significant problems in their pregnancy and labor. So we may need super support for these women. Not gonna, sorry. Oh my goodness. Okay, so you can kind of read through here. I don't believe there's any questions about cardiac disease on the exam. But just be aware, if mom's ticker isn't working well, then everybody's compromised. Gosh, this was a big section. So please just review these, okay? I do want to talk about peripartum cardiomyopathy just because I had a girlfriend who had this. She was a nurse, had a baby, almost died because of peripartum cardiomyopathy. All right, so it's basically a congestive heart failure type of situation. This happens to completely healthy women with completely healthy pregnancies, and then they go through labor and delivery. And what happened with my girlfriend is everything went fine. She was discharged from the hospital. She went home, and the night she was discharged, she went into congestive heart failure and almost died. Okay, so this is pretty rare, and they tell you that if you ever have this, never have it again, or never have another baby again. Okay, diabetes and pregnancy. I did want to cover diabetes and pregnancy. So at the first visit, so some women have diabetes, just straight overt diabetes, and then they get pregnant, okay? And here's your different kind of diabetes, type 1 and type 2. Type 1 is insulin dependent. In other words, besides their diet, they need to take insulin to control their blood sugar levels. And then type 2 is, they might be on oral glycemics, they might be on just diet, diet and oral glycemics, okay? And then you have gestational diabetes. So this is diabetes that occurs after pregnancy. During pregnancy, especially in the later part of pregnancy when it's the most problem, then they have a problem with carbohydrate metabolism and sensitivity to insulin, okay? So usually gestational diabetes can be managed on diet alone, and maybe some an oral hypoglycemic glyburide, I think it is, but I think I have it in the slide. So if they have gestational diabetes, they're at increased risk for having diabetes later in life. Okay. Oh my goodness. Oh, okay. So this is just kind of telling the physiology of diabetes during pregnancy. I'm going to let you kind of read through that. I want to get to testing. So we just gotta wait for this crap. I don't know how this happened. I don't know how to make it stop. I did that transitions thing or whatever it was, but alright. So the first part of pregnancy is usually not a problem. The second part of pregnancy is when the problem occurs. So our testing, oh my goodness. Okay, so if you have a woman coming in for her first prenatal visits and she looks like a patient that might fit some of the at-risk categories, you might want to test her for diabetes. Oh, wow, I can make it. Oh, wow. You might want to test her for diabetes. Oh, wow. Ketoacidosis is not where I wanted to go. Okay, I'm sorry. I'm trying to concentrate on this stupid slide stuff. Alright, this is where we want to be. Alright, so if you have a patient coming to her first prenatal visit and, stop doing that, and she looks like she's at risk for diabetes or gestational diabetes, you might want to test her right then and there, okay? And if you test her right then and there and she has abnormal blood sugars, then you could probably diagnose her with overt diabetes, not gestational diabetes. Because remember, and then make sure you read these slides, usually diabetes, gestational diabetes isn't a problem in the first half of pregnancy. It's the last half, which is why we screen all women at about 24 to 28 weeks. Okay? And they do what's called a glucose challenge test. Okay, so it is a 50-gram like oral glucose solution that they drink, and then they get their blood sugar checked 1 hour later. Now, if their blood sugar is 130 to 140 at that 1 hour check, then they're kind of on the fence. Is this gestational diabetes or what is it? So they want to do another test that's called a 3-hour glucose tolerance test. Okay, so in the 3-hour glucose tolerance test, they drink this. I think it's a 75 gram. I don't have it written here, and that's not good. It's a 75 to 100 gram glucose solution. And so they have to be fasting. Oh, there it is, 100 gram. Oh my goodness. They have to be fasting, and then you do a fasting blood sugar, and then they drink this 100 gram glucose solution, and then their blood sugar is checked at 1 hour, 2 hour, and 3 hour intervals. Okay, and then to diagnose gestational diabetes, 2 or more of the checks have to be elevated. So here are what the normal values are. So a fasting less than 95, a 1 hour after drinking this 100 gram solution needs to be less than 180. A 2 hour needs to be less than 155, and a 3 hour needs to be less than 140. If any 2 of those are abnormal or above those numbers, then she is diagnosed with gestational diabetes. Okay? All right. Hope that was confusing. No, I don't. I mean, I hope it wasn't confusing. Okay, so what do we do to manage these pregnancies? Well, it definitely is a team approach. Usually it's the obstetrician, maybe the perinatologist, and the endocrinologist, depending on if this is overt diabetes or a really bad gestational diabetes. And then we might even pull in the neonatologist if we're thinking that this baby is going to have problems after delivery. The dietitian and the diabetes educator is to help the patient with their diet. We may have these people on home blood glucose monitoring. We want their blood glucose to be 65 to 105 pre-prandial. So that's before eating. Okay? And then we'll test their blood sugars 2 hours post-prandial or 2 hours after eating, and we want it to be less than 120. Okay? If it's not those numbers, then they will get their dose of insulin, probably. Okay? Or we will adjust their diet and or try to get them to increase their activity, physical activity. Okay? So we have ongoing maternal and fetal surveillance. So we'll be doing ultrasounds. We're going to be measuring baby's weight. We're going to be checking amniotic fluid. We're going to be making sure we don't have any fetal defects, because especially with overt diabetes, especially if it's uncontrolled overt diabetes, you might have major malformations in the baby. Okay? So they'll be on insulin and or oral hypoglycemics. So some people have those subcutaneous insulin pumps, so we would just be helping them adjust that. If we're giving insulin without that pump, we'll be using those insulin pens. Let's see. And depending on how they dose the patient, whether they do a preprandial calorie counting or carb counting doses of insulin with a long-acting insulin, if we do a bedtime dose, so that would be a 4-dose regimen if we did all those. We don't give any oral hypoglycemics. I know I said that, but I was just being not slang, but just imposing my words. So because they cross the placenta, and we don't want babies to have oral hypoglycemics to decrease their blood glucose, because their blood glucose is just fine. But we do give the glyburide. That's a sulfonylurea, and it doesn't cross the placenta. Okay, so that's an oral medication that mom can take, and if we can control her glucose, is great. Okay. The one thing about diabetes and pregnancy is after baby is delivered, a lot of times mom's blood sugars do great for a period of time. If they're gestational diabetic, usually they don't have another problem with their blood sugars. Okay, but for babies born of mothers with diabetes, their risk factor is hypoglycemia after delivery, because sugar crosses the placenta, insulin does not. Baby's getting all this sugar from mom, and baby's producing their own insulin. We cut the cord, baby's no longer getting their supply of glucose, but they still have that level of insulin. So that drops their blood sugar, so we have to watch baby. I'm not going to go over thyroid conditions. Just know that blood clots are bad. We're on venous thrombosis now and pulmonary embolism. Pregnancy is a hypercoagulable state. So if we have a woman that has a clotting disorder or history of clots, they might be on heparin or Lovenox therapy during their pregnancy. Okay. And so we may even need to continue that during labor, just depending on what's going on with their clotting. So we might need to be watching them closely. I'm not going to go over psychiatric complications. Oh my gosh, I can't believe how long this lecture is. I'm sorry, guys. So chorionic villus sampling is so in the early weeks of pregnancy. This is antepartum fetal assessment. Okay. So chorionic villus sampling is something that we can do in early pregnancy. It's usually done about 10 to 12 weeks, where we're trying to get a sample of the trophoblastic cells, okay, which tell us a lot about baby, okay, and any type of genetic problems this baby might have. So we don't do these on a regular basis, but if we have a baby that we're really suspicious of genetic problems, we might check this out. So they have to go in by a catheter inserted right into the uterus to aspirate some of these trophoblastic cells. There's a lot of risk to this procedure: infection, fetal loss. We might break the bag of waters, that RH isoimmunization. So anytime you do an invasive procedure on an RH negative mom, you need to treat her with RhoGAM. And what we call fetal limb reduction. So the baby's only 10 to 12 weeks, super tiny, right? You put a needle in there, even though it's ultrasound guided, you might sever a limb. And when you sever a limb of a 12-week baby, it's pretty much done. It's toast, okay? Percutaneous umbilical blood sampling, where we can test, right from the umbilical cord in utero, anemia, if there's isoimmunization problem, metabolic disorders of the baby. Okay, PUBS is not PUBS is not on your exam, but I think CVS is. Okay. Amniocentesis, so that's when we go with a needle into the uterus to remove amniotic fluid, to test the fluid for all kinds of fetal cells. We can test for fetal lung maturity. We can test for chromosome abnormalities. There are risks to this. We can do this after 12 weeks. There are risks to this: rupture of membranes again. We can cause labor. We can cause infection, isoimmunization. We can test for fetal lung maturity. So really quickly, like these proteins are present to a certain degree when the lungs are mature. So when we are testing amniotic fluid, if we're not finding the correct ratios of these proteins or these compounds, or if they're present or not present, can tell us whether the lungs are mature. Now, we don't do fetal lung maturities anymore because we don't do preterm inductions or deliveries, okay? Preterm inductions, I'm sorry, unless there's a medical or obstetrical reason to do them. And if that's the case, they need to be done, okay? And it doesn't matter if their lungs are mature or not, okay? It would just be a heads up for the neonatologist or the NICU people that we have a baby without lung maturity, which we're assuming anyway, okay? So we don't do those anymore. They're not beneficial to us. There's a standard protocol on when you can induce and when you can't. So we don't induce people that are preterm unless we absolutely have to. The other scenario is just spontaneous preterm labors, and it doesn't matter what their fetal lung maturity is. We're going to assume they're immature, and we're going to be prepared for that. Okay. You can read about amnioscopy and stop doing that. Fetoscopy, I'm not going to go over those. Ultrasound, we can determine a lot about baby for ultrasound. We can actually see the baby. We can measure the baby. We can see abnormalities. We can see growth. We can see placental function. We can see through a fetal Doppler study. We can see about the blood flow through the umbilical cord. So those are other fetal surveillance deals. Fetal kick counts. So when we want to know how well baby's doing, we have mom do what's called fetal kick counts. These are moms just sitting down quietly, concentrating on baby movements, okay? We want 10 movements in 2 hours. Or we want movements that we want equal or exceeding movements from mom's previous. So what she usually feels from baby, we want at least that or more, okay? Or when she's actually counting, we want 10 movements in 2 hours. The philosophy to this is that sick babies don't move. So therefore, we would not feel any kick counts or count any kick movements, okay? So if we're not getting these movements, then we're concerned about baby, and we need to bring baby in for further testing. Doppler ultrasound flow studies, I'm not going to go through that. It's basically looking at the flow of the blood through the vessels, the umbilical vessels. Will tell us how well baby's getting blood flow. Non-stress tests, I do want to go over with you. This evaluates fetal well-being. It tells us about oxygenation of the baby, which tells us if the CNS is intact and if we have a good cardiac reactivity. Okay, we can do a non-stress test starting at between 28 and 32 weeks. Before that time, baby's central nervous system is not mature enough to do this test. Okay, but after about 28 to 32 weeks, this baby at some point in that little time frame, baby should become mature enough to do this test. But once baby does this test, is able to pass this test, baby should always be able to pass this test. So if they pass this test at 28 weeks and then they fail the test at 30 weeks, that does not mean that baby's central nervous system is immature still. That means something is wrong with the baby. So once they pass, they should always pass. Now, if they pass the test, we say that we have a reactive non-stress test. So this is really confusing, what I'm about to say. So I'm going to say it slow, and I want you to listen very carefully. A reactive non-stress test. So reactive means positive or yes. Non means no. Stress means stress, and test means we just test. So we have a reactive or a positive non-stress. So we have yes, non-stress, or yes, no stress. Do you get that? Okay. So a passing test is what we would say reactive non-stress test. Okay. So what we're looking for is, oh my goodness. So this should say 32 weeks. So greater than 32 weeks, we should have 2 fetal heart rate accelerations, 15 by 15. That means 15 beats above the baseline for 15 seconds in a 20-minute period. And then if they're less than 32 weeks, we'll take the 10 by 10s in 20 minutes, okay? Now, a non-reactive, non-stress test. So they do not meet those criteria. They're not having those accelerations. So non-reactive means no reaction, means negative or not good non-stress test. So they're having a not good non-stress. So no to non-stress. Do you understand that? No to non-stress. That means they're having stress. That's really confusing, I know, but that's the best way I know how to explain it. An unsatisfactory test is we didn't have fetal activity. We weren't able to interpret because we had we weren't having continuous tracings. Okay. Now, if the baby doesn't pass the non-stress test, the one last thing that we're going to do is what's called a fetal biophysical profile. And the fetal biophysical profile has 5 parameters. It has the results of the non-stress test, which apparently is negative because we just sent them for this test. And then they have an ultrasound. And in the ultrasound, they're looking at 4 different things. So look down through here. They're looking for fetal breathing movements. They're looking for fetal movements. They're looking for fetal tone, and they're looking at amniotic fluid volume. So each one of those parameters, baby gets either a 2 because it was good, or they get a 0 because it was bad. So the non-stress test, they would get 2 points if they passed. They get a 0 if they failed it. For fetal breathing movements, they want to see at least 1 movement in this 20 to 30 minute period, and they get 2 points if they have it. If they don't have it, they get 0 points. For fetal movement, they want to see 3 or more movements in this 20 to 30 minute period. If they see 3 or more, they get 2 points. If they don't see 3 or more, they get 0 points. Fetal tone, you can see they want to see an extension and a flexion. And so if they see that, they get 2 points. If they don't see that, they get 0 points. they look at the amniotic fluid level, and if their amniotic fluid level is greater than 5 centimeters, they get 2 points. If it's less than 5 centimeters, they get 0 points. So what does that mean when you add it all up? So when you add it all up, if their score is between 8 and 10, that's reassuring that we feel good about the baby. If the score is 6, we're not so sure if baby's okay. And if it's 0 to 4, we definitely know baby's not okay. So if it's 8 to 10, you go home, you live life, you be healthy. If it's 6, you might need to stay here in the hospital. Let us continue to monitor you and watch the baby. If it's 0 to 4, we need to deliver you now. Okay? All right. Vibroacoustic stimulation. So if we want to see some movement out of baby and we don't see it, we can do this little deal on the mom's abdomen. It's kind of like a vibrating noise, and it usually elicits a response from the baby. And so if baby responds good, if baby doesn't respond, then we need to do some further investigation. I'm not going to go over contraction stress tests because we rarely do them, but do look through those, and it's not on the exam. But we can do a contraction stress test. Basically what it is we get the woman to contract and we see how baby tolerates that, okay? So I'm not going to read on that any further. So I think that's all I'm going to cover there. So let me go on to chapter 14 quick. How long have we been? Oh my gosh, 2 hours and 20 minutes, guys. Thanks for hanging with me. I'm going to go through this one quick. This is complications during labor. So I'm going to let you read about dystocia. That's just a difficult labor for whatever reason. There's lots of reasons. Let me make this big. Hypertonic labor pattern. The woman's contracting very strong, very often. It's very painful, and the contractions are not changing her cervix. You can look at what we do to help with that. Babies are usually in the occiput posterior position. Okay, so that's the difficult position. It still can be a vaginal delivery, but more difficult. Sometimes we just stop the contractions, let mom rest, give her some pain medication, and then try to start over with her labor. Okay, hypotonic labor contraction pattern is she's not contracting enough to dilate her cervix. Okay, so one of the big reasons for hypotonic labor patterns is that there's so much in her uterus. So she's got this super huge baby. Maybe she's got more than one baby in there. Maybe she's got too much amniotic fluid. And maybe this woman has had lots of children. Okay, so what all that means to the uterus is that's overstretching the uterine muscle. Just like you overstretch a rubber band, it doesn't want to snap back into place. So the uterus does not want to contract well. So it doesn't change the cervix. So what do we do for that? We give the woman Pitocin. We augment her labor. Or we get her up walking around, changing her position. Okay, a precipitous labor is from the time she starts labor until she delivers her baby is less than 3 hours. Okay, so this is a super crazy time of 3 hours. Very strong contractions, very fast dilation, very fast. The woman's out of control, maybe very anxious. So you can read about that. It's not on your exam. You can read about problems with the pelvic structure causing problems with labor. Amnioinfusion, I'm going to tell you very quickly. Amnioinfusion is when we use an intrauterine pressure catheter, that internal monitor that measures contractions. If we need to, we can put some saline or lactated ringers through a port in the IUPC to put more fluid into the uterus. So this woman is in labor. She's got very low amniotic fluid. And remember, that can cause variable decelerations for our baby, because that's variable decelerations tell us cord compression when you don't have a lot of amniotic fluid in the uterus. then there's not a lot of cushion for the cord. So if the woman's bag of water is ruptured, we can put this catheter in, we can measure uterine contractions, and we can give her an amnio infusion. The important thing about this is to monitor how much is going in, how much is coming out. We don't want to put so much in and not enough come back out. Okay, that might cause problems for the mom. That might cause problems for the baby. So we got to continually monitor. Amniotomy is a fancy word for artificial rupture of membranes. So her bag of waters doesn't break on its own. We break it for her. Okay. The biggest risk with artificial rupture of membranes is what's called an umbilical cord prolapse. That means as all that fluid comes rushing out of the uterus, so does the umbilical cord. And then the head comes settling down on that. So we've got umbilical cord sitting in the vagina, and the head is compressing on that cord. That means it's stopping blood flow to the baby. This is an obstetrical emergency, and we need to rush to the OR. On her way to the OR, the nurse does a vag exam. She puts her hand or fingers on the head and pushes the head back up into the uterus to get the pressure off the cord so we can get some blood flow to the baby till we can get to the ER or OR and do an emergency C-section, okay? But when we break their bag of waters, the other thing we need to do is we need to monitor the fluid. If we don't have the umbilical cord prolapse, okay, because we're done with that. If we break the woman's water, we always assess the fluid, the amount, the color, the consistency, the clarity, and the odor, because we're wanting to know, is there any meconium in this amniotic fluid? If there's meconium, that's the baby's first poop. If there's any meconium in the fluid, then we run the risk of baby aspirating that and getting a meconium aspiration syndrome. That's very bad for baby, okay? Sorry, I'm running through this because I am. So please call me and we can talk about this if you have any questions. Induction of labor and cervical ripening. Okay, so we use a thing called a Bishop score rating to determine if the woman is inducible. Is her cervix favorable or inducible for induction? Okay, so we can induce this woman all we want, but if that cervix isn't ready to dilate, it's not going to. Okay, so when we do the Bishop score for the first time pregnant laboring patient, if she has a score greater than 9, then her cervix is favorable. For a woman who's had multiple pregnancies, if her Bishop score is greater than 5, then her cervix is favorable. And here is that Bishop score. So we give her a score based on dilation, effacement station, the consistency or the way the cervix feels, and the position of where that cervix is in her vagina. She gets a score, we add it up, and you saw what is good scores. So how do we ripen the cervix to get it ready for labor induction? So ripening the cervix makes the cervix softer so that it will dilate and efface. We use a couple of different medications. Okay, Cytotec or Cervidil. I'm going to go over Cytotec because 99% of the time that's the one you're going to see in the hospital. And you can read about Cervidil just for your own education because it might be on your NCLEX exam. Cytotec is a pill. It's an oral pill that we cut because it comes in 100 microgram tablets. We cut it into 4 because we only give 25 micrograms. We put it in vaginally up by the cervix. We give it every 4 hours till we get regular uterine contractions. After we get regular uterine contractions, we can start Pitocin 4 hours after the last dose of Cervidil. Okay, I'm sorry, after Cytotec. I will tell you about Cervidil real quick. Cervidil is like soap on a rope. It's a prostaglandin that is in the form of like a little tiny cloth paper connected to a string. We put that up in her cervix. We leave it in there for 12 hours and then we pull it out. After we've taken that out after 12 hours, then we can start the Pitocin either 30 to 60 minutes after we've pulled that out. Okay, you can see the contraindications. There's mechanical methods to doing cervical ripening, and they're called balloons, either a Foley catheter balloon or a cervical ripening balloon. A cervical ripening balloon, it looks just like a Foley catheter, except it has two balloons instead of the one. We place that into the cervix, and it goes on the internal os. One balloon goes on the internal os. We fill that up in the uterus. The other balloon is on the external os in the vagina. We fill that up. Those balloons create pressure on the cervix, which causes them to ripen. Another thing they can do is what they call membrane stripping, is when the primary care provider or the OB does a vaginal exam. He grabs a hold of the bag of waters and kind of rubs it between his fingers. That releases hormones that may stimulate labor. Nipple stimulation is another way to get labor going, and intercourse is another way to get labor going. But after we've got labor going, then we will use oxytocin as our induction agent. We can use oxytocin as our augmentation agent. So she's in labor on her own, but it's just going really slow or it's stalling, so we'll start the oxytocin, okay? There's a strict protocol to follow when managing oxytocin. It's a very dangerous drug. We give too much of it and we rupture her uterus and kill her baby, okay? So I'm being dramatic because I'm going fast. So we have to follow this protocol. It's very precise. And we have to do constant monitoring of her uterine contractions and of her of the baby's heart rates. Okay, so usually we start with 2 milliunits a minute, which actually equals 2 cc's per minute, or I'm sorry, 2 cc's per hour. Okay, we increase it by 2 milliunits per minute, which is 2 cc's an hour, about every 30 minutes. We want to get a contraction pattern of 5 contractions in a 10-minute period, okay? If we get too many contractions, that's called tachysystole. We need to turn down the Pitocin, usually by half. But if we're running Pitocin and we have fetal heart rate problems, we just absolutely turn it off, period, okay? We can restart it within 30 minutes if we've recovered the baby and the baby looks great. And then when we restart it within 30 minutes, we start it at half the dose that we had turned it off at. So if we were running at 10 milliunits per minute or 10 cc's an hour, we restart it at 5, okay? But if it took us more than 30 minutes to settle baby down, then we start the whole protocol over. All right, sorry that's fast. I'm going to jump through that. Forceps assisted delivery. So that's when the woman is pushing and pushing and pushing and she can't push anymore and the baby's right there. They put these forceps into the vagina. They clamp onto the baby's head, and actually they don't clamp on, but they are secured against the baby's head, and the physician provides gentle traction as the woman pushes to help deliver the baby. We can do an episiotomy to provide more room. But you can see there's a lot of trauma that can happen to both mom and babe, so we need to be monitoring these people after delivery very closely, especially the baby and the baby's head. So we need to watch that baby's head for bleeding, okay? Here is what forceps look like, and you can see how they're applied, okay? The other one is a vacuum-assisted delivery, where we put this little suction cap on the baby's head, and again, with gentle traction, with pushing, we guide the baby out. The one thing about forceps is we put this suction cup on the baby's head. We pump up the suction, and there's a green zone. So that's where it's an appropriate amount of suction not to cause trauma to the baby's head. That's where the physician needs to keep it, and that's where you need to make sure they have it, okay? And then they do this gentle traction. If they're doing this gentle traction and the suction cup pops off, then they can reapply it. But they can only do that twice, and then you need to step in and tell Mr. Physician that he's done using the vacuum, because that will lead to problems for the baby. Bleeding, lacerations to the head, bad problems, okay? So here's what it looks like. This is what their poor little head looks like after its use, okay? We've talked about hypertensive disorders. We've talked about preterm labor. We talked about shoulder dystocia in our OB lab on that first Monday of classes. Amniotic fluid complications, so oligohydramnios means there's not enough fluid. That could tell us that there's problems with our baby. And if we have not enough fluid, then it's not cushioning the cord. So we could get cord compressions and we'll see variable decels. If that's the case, we can do that amnio infusion we talked about a few minutes ago. Hydramnios is too much amniotic fluid. We can see this. We can see some problems with the baby if we have too much fluid. We need to watch for prolapse cord when the water breaks, that where the cord flows out of the vagina. That's not good. Meconium aspiration, so we talked a little bit about that. So if we do have meconium stained fluid, we need to deliver this baby, and if the baby is vigorous and crying, then if they had meconium in their airway, they've already sucked it down, it's too late. But if they're vigorous and crying, they probably don't have a problem. But if they're not vigorous and crying, we take the babies as quickly as possible over to the warmer, we intubate the baby, we visualize cords, and we suction out the cords to get any meconium out we possibly can. Nuchal cord is just when the umbilical cord is wrapped around the baby's neck. So when the head's delivered, before the rest of the body's delivered, generally the physician will take his fingers and feel around the baby's neck, make sure there's no cord. If there's a cord, they just try to slip it over the baby's head. If the cord is too tight around the baby's neck, they squeeze in forceps, clamp off the cord, and cut it right then and there. And then they can deliver the rest of the baby's body. Okay? We talked about placenta previa, we talked about abruption, we talked about DIC. Uterine rupture, so that is a complication usually associated with previous C-sections, and the woman wants to try to have a labor. A woman can have a uterine rupture even if she hasn't had a previous C-section, but usually it's associated with previous C-sections or traumas to the uterus or surgeries to the uterus. Okay, this is a medical emergency, so the uterine tissue muscles have ruptured, have torn, so she's bleeding. Okay, so this is an obstetrical emergency. Uterine inversion is when the uterus, and this is after the baby's born, when the uterus turns inside out and sometimes is pushed out of the vagina. So we just have to be careful with our fundal massages. It can be very painful. We do need to put that uterus back in, and we need to give antibiotics to prevent infection. We talked about umbilical cord prolapse. Let's go over this really quick. Umbilical cord and placenta abnormalities. So a valimentous cord insertion. These are not on your test, by the way, but I do want to cover them because these are high-risk obstetrical situations, and we may see patients like this in our clinicals. So valimentous cord insertion, it's when the fetal vessels separate from the cord, from the placenta, and they they separate from the placenta, so you have exposed cord. They're not covered by the Wharton's jelly, so umbilical cords are covered by a jelly squishy substance called Wharton's jelly, and it's what protects the vessels in the umbilical cord. Okay, so with valimentous insertion of a cord, there's a portion of the cord that has that is exposed, basically, without any Wharton's jelly. So that's a problem that could present a bleeding problem or a cord accident problem for the baby. Vasa previa, just like a placenta previa. So a placenta previa is when the placenta is over the cervical os. So a vasoprevia is when those umbilical cords, so those exposed valimentous cord insertion, those exposed vessels of the baby's cord are over the cervical os. So that could be a huge bleeding issue. I am actually going to let you read over these because they're not on your exam, and I'm just trying to be quick for you guys. Circumvallate placenta is a deformed looking placenta. Saccentuate placenta is another type of placenta. We're going to show you pictures of these, so you basically can see the picture and then see what these things look like. A Balador placenta, and here's what they look like. So the first one is the velamentous insertion. So I told you that the umbilical cord is not, there's a portion of the umbilical vessels that are not covered by the Wharton's jelly. They're not in this great spiral. It's these cords right here that are just coming out of the placenta. They have no protection at all, okay? The circumvallate placenta, so there's this, you see this like white stuff? So this thing, so we have the cord coming down, we have exposed vessels, so it's basically this, but there's this covering over them, okay? So they're not covered by Wharton's jelly. They're and they could be traumatized. Okay, so this is dangerous for the baby. Sescensuate placenta. So we have our placenta here, and then we have this other little thingy majig placenta-ish deal over here, and then we have vessels between both of them. Okay, so that's kind of freaky deaky. And then we have the Balador placenta, so that's this one. So we have, the placenta is supposed to look like this. The umbilical cord is supposed to come down right in the middle of it. Okay, and so this is kind of off to the side of the placenta. And these vessels are stretched out over this way. So these could be exposed and in jeopardy of being harmed. Okay. Oh my gosh. So other placental problems. Placenta accreta, increta, percreta. So this has to do with, so the placenta implants in the endometrial lining of the uterus. So these implantations they go deeper into the uterine lining, which makes it a problem for delivering this placenta after the baby is born. So they're deep into the myometrium. We can't get them out of the myometrium. Remember, the myometrium is the inner layer of the uterus, and so like they're embedded in there. So getting these placentas to break away after they're embedded into that layer of the uterus is very difficult. So this could cause retained placenta. This could cause bleeding, hemorrhage, really bad stuff for mom. Okay, so the placenta accreta is this is the way that I remember these. The placenta accreta is at the myometrium. A for at, A for accreta. So just a very slight penetration into the myometrium. The placenta increta, I for in for in. So it penetrates deep into the myometrial layer. So it's into the myometrium. Okay, and then the placenta percreta has penetrated through the myometrium, and this one is really, they're all really bad. Okay, so this could cause severe bleeding for mom and possible complete hysterectomy. Her uterus would have to be removed in order to stop this bleeding, because we can't get the placenta out from this layer. Okay, I'm going to have you read over anaphylactoid syndrome of pregnancy. This is very rare. It's not on your exam. We used to call it amniotic fluid embolism, but I'm going to let you read over that. It's this is super bone chilling. I do have a patient that we did have a patient that had this a couple years back at CMC. So if you want to ask me the story, I'll tell you about it. Baby did eventually die. Mom almost died. Went into renal failure, liver failure, the whole 9 works. It was really super bad. Anyways, so perinatal fetal loss. There is a question about this on your exam, but it's basically how do you respond to the. So there is a fetal loss. How do you respond to the family? Okay. So here's what you can say, and here's what to say. What not to say. Do not say, well, it was God's will, so get over it. Don't say that. Or don't say, you can just have another baby. Come on, quit worrying about it. Don't say that. There was some sort of freaky problem with your baby. You should be glad you lost this baby. Don't say that. There's always next time, so get over it. Don't say those things. Acknowledge the baby's life in utero. Acknowledge the baby's death. say comforting words or don't say anything at all, and just be there with the patient, okay? Cesarean births, I'm going to let you read over this. There are some questions on cesarean birth. Let me see if there's, okay. Sorry. What is on there about cesarean birth? Actually, I don't know that there's anything on there about cesarean birth. I will read over what's on the exam, okay? But read over cesarean birth. I will tell you about cesarean birth. There's a couple of different incisions that they can do on a cesarean birth. There's the classical or vertical. So that is usually reserved for emergent deliveries, emergent deliveries. And if she has a classical or vertical C-section, she cannot attempt a vaginal delivery because it has cut through that entire muscle of the uterus. So having contractions on that entire incision is very dangerous. The low segment transverse cesarean section is the one that we usually use. And they can have a vaginal birth after that, okay? So running through that, this is the prep. This is the pre-op prep. Here's the intra-op care and the post-op care. So look at that really quick. When they do have a vaginal birth after cesarean, it's called a VBAC. That is a vaginal birth after cesarean. Their labor, however, is called a TOLAC. Trial of labor after cesarean. So they try to labor, and if they get to the vaginal birth, then it's a VBAC. Okay. Post-term or prolonged pregnancy. Please look over these. Please look over this section. The one thing about post-term babies is you would think that they would be the size of a 3-month-old baby, and sometimes that is the case. But sometimes it's not the case. So the placenta stops functioning at about 40 weeks, or it starts deteriorating about 40 weeks. So you either have this big healthy 3-month-old baby at 42 weeks, or you have a baby who is suffered intrauterine weight, and they look like this shriveled up old wrinkly man. Okay, so look at your risk factors associated with a baby who's 42 plus weeks. What can happen for baby, what can happen for mom, and how we manage that. Okay, now we're done. So I am super sorry that this was such a super long recording. I do want to tell you about the things that are going to be on the quiz that you need to make sure that you understand. Look over into last week's lecture about complications from spinal anesthesia. What's the number one complication for mom for spinal anesthesia from a spinal or an epidural, and how do we treat that? Okay, so it has to do with her blood pressure. Okay, so what do? We prehydrate her. Okay. So fetal positions in labor, OA is the great position. OP is where baby is sunny side up or backwards. So that's a more difficult labor position. Oh yes, do look over anaphylactoid syndrome of pregnancy. Do look over that, please. Look over forceps and what could happen to the baby in response to a forceps delivery. Know how to count the frequency of contractions. Know the different ways the baby is lying in the belly. Okay, so this is different from being occiput anterior or occiput posterior. This has to do with, is the baby head down? Is the baby shoulder presenting? Is the baby oblique, transverse, longitudinal? Which way is baby lying in there? Look over the part where I talked to you about mag sulfate and our assessment and the different levels of serum magnesium levels. Okay. Look over the DVT in pregnancy, deep vein thrombosis, and what the appropriate treatment is during pregnancy and what the appropriate treatment is after pregnancy. Look over diabetes. Know the different types of abortions, spontaneous abortions. Know what happens to baby when we give potent narcotics like Dilaudid when baby is in utero and for mom's pain, and then we give this narcotic to mom, and then all of a sudden she delivers, and then what do you expect for baby's response to be from that drug? Okay. Know about nitrazine paper and how what it says about whether or not the woman has rupture membranes or not. So what about the care of the mom after she's given birth to a baby and she had an epidural and she's ready to get out of bed? What kind of anesthesia do we typically use for a C-section? Usually that's a spinal. Okay. Understand what baby heart rates are, so what a normal baseline is, what variability means, and the different types of variability: absent, minimal, moderate, marked. Know about the fetal heart rate decelerations. There's the variable deceleration, there's the early deceleration, and there's the late deceleration. Know about the different types of breaches. Remember when we talked about last week, you could have all butt with the legs straight up. You could have the butt with the legs flexed in front of the baby. You could have the feet. Know about those different ones. Know why we do an amnio infusion. Know what to do if we determine that the baby is in an OP position. Remember that if we change mom's position, we might change the baby's position. So if we rupture mom's membranes, in other words, we do an artificial rupture of membranes or an amniotomy, and we have decreased fetal heart rate, what do you think is going on there? What to do? I've already said this, but what do you do to prevent hypotension from an epidural? What do we do to mom before the epidural is placed? What's the first thing we do for bad fetal heart rates? Like the first and most basic thing we do is change mom's position. What is the benefit for using an opioid in with the local when we do an epidural? What can we do? What can the partner do to help the woman in labor who's having back pain? What can we do to prevent a laceration, a perineal laceration during birth? What do you do basically to treat hypotension in a mom? What does the mnemonic poison stand for? What is a uterine abruption, and what do we need to watch out for? If mom has delivered her baby and all of a sudden she has hypotension and tachycardia, what do you think's going on, and what will you assess? When we do use Cervidil for cervical ripening, when can we start Pitocin? What do we do when we're using Pitocin and we have too many contractions? What are the treatments for an ectopic pregnancy? What are some signs of preterm labor? especially the signs that are related to what we're going to see with ultrasound. When you do a urine dipstick to test for protein urine in the mom, and you find an abnormal amount from a urine dipstick, what is another urine test that you can do to confirm proteinuria? Why do we give betamethasone? What kind of labs do we do when a woman has severe preeclampsia? What is the benefit of using a birthing ball in labor? And what are the different kinds of what are the different types of hypotension in pregnancy? Okay, so if you are aware of those things or know a little bit of something about those things, you should do well on the exam. Again, I apologize for the length of this lecture. Please call me if you have any questions.